A very good morning to everyone and welcome to this
A very good morning to
final lap
everyone
where we
and
will be
welcome to
covering
this
surgery,
very good morning
ophthalmology
to
and
the
ENT.
lab.
So my dear friends, ENT we get for 17 marks, optho we get for 13 marks and surgery we get for 35 marks. So in total, how many marks subjects we are gonna cover? So this is gonna be a 30. This is so total we are going to cover 65 marks a subject. And very good morning and welcome to everyone at the Conceptual Medicine channel by Dr. Bhanu Prakash sir. You know Bhanu Prakash. Bhanu Prakash sir is having largest YouTube channel with more than 1 million subscriber, and also they are having the largest FMG telegram group with more than 1 lakh subscribers. So they are continuously providing free content to all the FMG NEET PG aspirants. So we are very thankful to sir for organizing such sessions. So today in 4 to 5 hours we are gonna complete this 65 marks ka subject. So it is going to be the blockbuster and game changer in your exam preparation. So you have to be there. So first subjects we are going to do is gonna be your ophthalmology. Are we all ready? एक बार सुबह सुबह जोश पूरा दिखना चाहिए मुझे. I will pass. I will pass. May God bless you all. And today we are only left with, today is 20th and we are left with only 5 days, including today. It's 20, 21, 22, 23, 24, 25. 6 days are there. So every day, if we are going to study for 30 marks, still we are getting 180 marks, my dear friends, and all of us are getting pass. All of us are getting pass. No doubt in that. Zero doubt in that, sir. Okay. So आज भी पढ़ना स्टार्ट करोगे तब भी पास हो जाओगे, पहले से भी पढ़ रहे हो तब भी पास हो जाओगे. कुल मिला के आप सारे के सारे पास होने वाले हो. ठीक है, चलिए लेट्स मूव ऑन टू द नंबर 1 पार्ट, दैट इज द एनाटमी ऑफ द आई. Okay. So my dear friends, anatomy of the eye, we have to study about the 3 layers. If you see this beautiful diagram, we are dividing this diagram into 3 layers. There is a outer layer, middle layer and inner layer. Every layer is very very important. So outer layer mein we are having a cornea. Cornea is a structure which is a avascular. Question number 1. The only avascular structure in the eye would be your cornea. Would be your cornea. Good morning, Dr. Sunil. Then white part is called as sclera. Then coming limbus. Limbus where your zonules are there. Okay? Ciliary muscles and zonules are there. Then coming to the middle layer. Middle layer is also called as uvea. There's a mnemonic called as ICC. So I stands for Irish, which will decide the color of eye. Color of eye. The color of eye is decided by iris. Ciliary body is having 2 structures, pars plana, pars plicata. This pars plana and pars plicata are secreting something called as aqueous humor. The 2 type of fluids are there in the eye. One is aqueous humor, another is what's your vitreous humor. Aqueous humor and vitreous humor. Then coming to the choroid, the most vascular structure in the eye is gonna be your choroid. The most avascular structure is gonna be your cornea. White part is limbus. White part is sclera. Then ciliary body is having pars plana, pars plicata, which is secreting your aqueous humor. Done, 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 done. ठीक है साहब. Now coming on to the innermost part, that is your retina. So telling about the orbit का volume कितना है, eyeball का कितना है. The orbital volume is 30 ml. Out of 30 ml, only 6 ml is your eye wall, and out of 6 ml, 4 ml is your vitreous humor. So question comes, which is the largest structure in the eye? The question comes, which is the largest structure in the eye? Which is the largest structure in the eye? The largest structure in the eye is gonna be your vitreous humor. Is gonna be your vitreous humor. Is gonna be your vitreous humor. Done, done, done. Coming on to the next one. Sir, orbital blowout fracture. Orbital blowout fracture, the most common, the fractured part is gonna be your inferior wall. And the moment there is a fracture of an inferior wall, you are going to see the break, and from break there is a tissue coming out. This is looking like a teardrop sign. This is a previous year question of the FMG exam. This is gonna be your previous year question of the FMG exam. Now coming to the triad, what you are going to see is a ETH triad, a very famous triad called as ETH triad. Sir, E stands for anophthalmos, I stands for infraorbital anesthesia, and D stands for diplopia. So there is gonna be anophthalmos, eye is gonna be going inside. There is gonna be the double vision also, which is called as diplopia. Due to the paresthesia, you will see the intra or infraorbital anesthesia. You will lose sensation under the orbit. तो ये होगी दो चीजें. Then coming to the next, the avascular part of the eye. हमने पढ़ा था avascular part of the eye, that is going to be your cornea. And cornea ka function is to bend the light, and this is a transparent avascular structure, bending of the light. Now you will see the curvature and the thickness. Two things are very important in the cornea. One is curvature, another is thickness. So curvature is tested with the help of keratometry, previous year question, and thickness is measured with the help of pachymetry. This is pachymetry and this is your keratometry done with the help of placido disc. The image based question can come in your exam, and you all are going to pass this exam. Done. So coming on to the next one is refractive index. Next is gonna be what's a refractive index. For the air, it's gonna be 1. For cornea, it is 1.37, and lens, it is 1.38 to 1.40. And question comes, where is maximum in the lens? Then your answer is gonna be the center of the lens is having maximum, and how much it is. This is gonna be your 1.40. Then coming to the next one is uvea, as we discuss ICC. Iris will decide the color of the eye. Okay. Choroid, ciliary body is having two structures, pars plana, pars placata. What they are secreting? Can you answer me in the chat box what they are secreting? They are secreting the aqueous humor. Then coming choroid, most vascular structure. So everything we are revising, we have studied in the speed, 2x speed we are doing this. This is what you need to do before the exam. Then coming to the ciliary body. Ciliary body, we are having pars plicata and pars plana. They secrete the aqueous humor, and another fluid is called as vitreous humor. Vitreous humor is the largest structure in the eyeball. Done. Choroid is the most vascular structure drained by vortex vein. अगर यहाँ पे blood supply ज़्यादा, if there is more blood supply, they are gonna do one more function that is called as thermoregulation. That is called as what, sir? Thermoregulation. To regulate the temperature of the eye is called as what, sir? Your thermoregulation. Now coming the next one is called as retina. Retina is the innermost layer, and the thinnest part of retina is called as MCQ. That is your ora serrata. Then center of retina is having three structures. What are the three structures we are having? Macula, fovea, optic disc. Now most sensitive to light, सबसे ज़्यादा sensitive कौन है light को? That is your fovea. And your optic disc का diameter is also very important. That is gonna be your 1.5 mm. In the disc edema, you will see the this millimeter is more. 1.5 से ज़्यादा हो जाता है, and that is going to be problematic. We are going to discuss in different diseases. Coming on to the next one, the cells we are having there in the eye are rods and cones. Rods are of one type, cones are of three type. What three type of cones we are having? Red, green, blue. सबको पता है. Rods are one type, present in the periphery, used for the day and night vision. That is black and white vision. If we talk about the cones are having three. They are for the color vision, which is also called as photopic vision. So black and white vision is also called as scotopic vision, and your red, green, blue is also called as photopic vision. Now question comes, which is the first cell to receive light, most sensitive to light was different. That was what? Your fovea. Now question comes, which is the first cell to receive the light? Then it is gonna be your rods and cone. Rods and cone. Okay. Now about the lens and the pupil, what they are dividing. In the eye, we'll see one is chamber, another is segment. How will dividing it? Very simple. Lens is sounding like a length, and length is present in segments. So remember, anterior and posterior segment is divided by length, and pupil divide anterior and posterior chamber. Chalo. Now coming on to the aqueous humor. Aqueous humor. That is also a fluid which is present in the eye, which is produced by MCQ, ciliary body. What part of ciliary body? Pars plicata, more common than pars plana. Both are secreting pars plicata and pars plana. Done. The production rate is 2.5 microliter, but outflow rate is 0.2. What will happen if this aqueous humor is continuously secreting, but not going out? Then there will be a disease called as glaucoma. Then there will be a disease called as what, sir? Your glaucoma. Then coming to the vitreous humor, this is present by birth. 98% is water, 2% hyaluronic acid is there. 98% water is there and 2% hyaluronic acid is there in the vitreous humor. So two fluids are there, aqueous, vitreous. Aqueous humor by throughout the life produce होता है, vitreous humor present by birth होता है, volume इसका 4 ml होता है. So eye wall का volume is 6 ml. Out of 6 ml, 4 ml is your vitreous humor. That's make your vitreous humor the largest structure in the eye. That makes your vitreous humor the largest structure in the eye. Then is gonna be your power. Eye ka power is 60 diopter. It is 58.5 something we are taking, sir. Now coming to the cornea is 43 diopter and the lens is gonna be your 19 diopter. Lens is gonna be what, sir? Your 19 diopter. 19 diopter. So these are the powers we have to remember for the eye lens and cornea. Now, sir, anterior posterior diameter, or which is also called as axial length. What is the normal axial length of an adult eyeball? That is your 24 mm. But at the time of birth, this is small, which is 16 mm. And this will cause physiological hypermetropia. Physiological hypermetropia में तो पास का नहीं दिखेगा, दूर का दिखेगा, है ना. Far sightedness would be seen, sir. Then coming to the next one, that is your nerve supply of the eye. My speed is fine for all of you, or I need to decrease or increase it? Please let me know according to your comfort. See what we are going to do. क्या चल रहा है कि स्पीड कम करके चलना है, कैसे चलेंगे ये आप ही लोग डिसाइड करोगे, सर. ठीक है, चलिए. So nerve supply of the eye, the two things are there. One is parasympathetic, another is what, sir? Sympathetic. ठीक है. पैरासिम्पैथेटिक एंड सिंपैथेटिक, इफ वी रिमेंबर, पैरासिम्पैथेटिक पैरों के नीचे सारी चीज़ बढ़ाता है, सिंपैथेटिक पैरों के ऊपर बढ़ाता है. तो अगर आपकी आई डायलेट हो रही है तो सिंपैथेटिक इज वर्किंग. इफ इट इज़ मियोसिस देन पैरासिम्पैथेटिक इज वर्किंग. वेरी सिंपल. पैरासिम्पैथेटिक में आंख का साइज छोटा होता है, सिंपैथेटिक में आंख का साइज बड़ा होता है. पैरासिम्पैथेटिक देयर इज अ मियोसिस एंड सिंपैथेटिक देयर विल बी अ माइड्रियासिस. तो पैरासिम्पैथेटिक इज बाय थर्ड नर्व, सिंपैथेटिक इज बाय द फिफ्थ नर्व. सो थर्ड नर्व इज पैरासिम्पैथेटिक, फिफ्थ नर्व इज योर सिंपैथेटिक. Then coming to the next topic called as vision. My dear friends, if we talk about the vision, normal vision is gonna be your 6/6 and max possible is 6/3. Now question comes, what about blindness? Can anyone guess? What about the blindness? Blindness की क्या करेंगे? Blindness की what is the definition of blindness? Anyone just put that message in a chat box कि definition of blindness क्या है? That is also very important. So your normal vision 6/6, max possible 6/3. Yes, the blindness is 3/6 with best possible correction in the better eye. Complete sentence है, best possible correction in the better eye is gonna be the important part. Yes, very good. Now coming on to the charts of the vision. So first of all, the most commonly used chart is gonna be your image-based question exam, and that is none other than your Snellen's chart. So the most commonly used chart is gonna be what's your Snellen's chart. If the person is illiterate, then you are going to use landlord's ring. And if the baby is less than 3 years, we call that as toddlers or preschool children. In that we use this Allen's chart. And if the baby is pre-verbal, less than 2 years, then we are going to use the optokinetic run. And the best chart, which is looking like a sunset sign, this is gonna be your Logomar chart. Logomar chart. So these are the 5 important charts which are important to remember for the vision. So vision का sequencing क्या है? First of all, if you have to check the vision, you will see the chart. Chart से काम नहीं चला, you will show the fingers. If fingers also he is not able to see, you will wave the hand. And if waving hand is also not seen, you will put the torch. And if torch is also not seen, then you consider that person as a blind. Person as blind. ठीक है? Less than 3/60. Yes, true. Now coming to the chart. भाई साहब, चार्ट के बाद में आई फिंगर. फिंगर के बाद आया वेविंग ऑफ हैंड, एंड आफ्टर वेविंग ऑफ हैंड व्हाट इज देयर? टॉर्च. अगर फिर भी नहीं दिखा then we consider that person as blind, ठीक है. चलो, now coming on to the next one, intraocular pressure. Intraocular pressure is exerted by both the fluids. What both the fluids we are having in the eye? One is your aqueous humor, another is what are your vitreous humor. Sir, एक aqueous humor है, दूसरा vitreous humor है. Normally your pressure in the eye is gonna be 10 to 21 of mmHg. But in glaucoma, what is happening? Either this fluid is over secreted, not going out, either it is secreted normally, but the meshwork trabecular fibrosis is there. That is close angle glaucoma and open angle glaucoma. We will be studying in the topic of glaucoma separately, because glaucoma is gonna be your 100% exam question on 26th of July. And also this vision is gonna be a question. In ophthalmology, total 40 to 50 topics are there. Out of those 40-50 topics, we are gonna cover at least 40 topics. That's my promise to you. And out of these 40 topics, your 13 will be question in your exam, directly or indirectly. All the topics will be covered in the exam. इक्का दुक्का क्वेश्चन छोड़ दो, बाकी सारे टॉपिक्स में से ही आएंगे. Now, intraocular pressure is measured by a MCQ, a previous year question, that is gonna be your tonometer. And the best tonometer you have to remember is a Goldman applantation. The best tonometer is gonna be what's your Goldman applantation. Now coming to the visual field, भाई हर जगह एक जैसा नहीं दिखाई देता है. Laterally देखो, ऊपर देखो, nasal में देखो, visual field is different. So this visual field is measured with the help of a device called as Humphrey's perimeter. Again a question. Now the intrapupillary distance normal is 65 mm. If it is not maintained, we call that as what's a squint. Plus, where is maximum? So maximum is gonna be on the temporal side. How much? This is gonna be your 100, my dear friend. Oh my God, sir. सुबह distract कर रहे हो sir. क्या दिखा रहे हो sir? So temporal is gonna be your 100. Inferior nasal is gonna be your 70, 60, and superior is also what's your 60. Superior is also what's gonna be sir your 60. Done. So this is for the visual field. This is for the charts most commonly we were using. Now it's time for Viva, and you people have to answer my 2 to 3 question. First of all, in the children less than 3 years, which chart we are using for the vision testing? Question number 1. Question number 2 says, what are the 2 fluids in the eyeball? Question number 2, 2 fluids in the eyeball. Question number 3, visual field is measured with the help of. Visual field is measured with the help of. Visual field is measured with the help of. Then what is gonna be your answer? Sir? Visual field is measured with the help of. Yes, sir. Answer to 1. Question number 1 is Allen's chart. Very good. Question number 2 is 2 fluid, aqueous and vitreous humor. Very good. Then visual field is measured with the help of Humphrey's perimeter. Done. Coming on to the color blindness. Next topic is color blindness. That if you see, color blindness is nothing but X-linked recessive. What do you mean by this X-linked recessive? Female are carrier but never diseased. Females are carriers but never diseased. Female carry तो करती है but female को कभी भी बीमारी नहीं होती है. So person is basically confused for the color. So you will see the name of colors is now Pro, Deutor and Tritan. So your Pro, Deutor and Titan is a color name. Pro color is red color क्योंकि सब जगह सबका favorite होता है. Deutor is like a Dettol का bottle, green color का होता है. Tritanopia is Tridev, Mahadev, blue color होता है. So remember Proto, Deutor. And if a word is written Nopia, that means cone is absent. If word is written normally, that means there is a weakness of the cone. So absence of the cone, weakness of the cone. If there is an absence of the cone, that is gonna be complete absence. ठीक है. And if there is a weakness of the cone, there will be a blurring. So what do you mean by the term called as monochromatism? अगर आपके ये कोन एब्सेंट हो जाते हैं, ओनली रॉड्स आर प्रेजेंट, एंड रॉड्स आर फॉर स्कोटोपिक विजन, दैट इज फॉर नाइट विजन, तो यू विल सी world as black and white. You will see world as what's are your black and white. Done. Now जैसे विजन टेस्ट करे थे वैसे ही कलर ब्लाइंडनेस के भी टेस्ट करने हैं. इसके लिए भी चार्ट्स होंगे. सो नंबर 1 चार्ट, मोस्ट कॉमनली यूज चार्ट is gonna be your Ishihara. Which number you are gonna see here, sir? 12. This is gonna be your 33. this is 38, this is 74, and this is your 69. So my dear friends, if you are able to see these colors, that means you are not colorblind, and people who are colorblind, they will be having difficulty in seeing these colors. Then coming FM100 Hui chart, and the best is Nagel's anomaliscope, which is a previous year question of the FMG exam. So till here everything is fine, going fine. Please give me thumbs up in the chat box if everything is going fine. चलो जी, सब प्यार से मज़े मज़े से चलता रहना चाहिए, ठीक है। अभी कुछ लोग सो करके जग रहे हैं, दे आर जॉइनिंग अस नाउ, सो वेलकम वेलकम वेलकम। जागो जागो, पेपर आ गया है, 26 तारीख को आप पास होने वाले हैं। सो लेट्स टॉक अबाउट द ऑक्यूलर मूवमेंट, द मसल विच आर हेल्पिंग इन द आई ओपनिंग एंड द मसल विच इज हेल्पिंग इन द आई क्लोजिंग। तो क्लोजिंग के लिए ओनली वन मसल इज रिक्वायर्ड, ओपनिंग के लिए भी रिक्वायर्ड कम से कम भी 3 मसल्स, कम से कम भी 3 muscles. So remember my dear friends, what are the 3 muscles which are helping in eye opening? That is gonna be your LPS, levator palpebrae superioris, molars and frontalis. ठीक है, so LPS, molars and frontalis is gonna be 3 muscles, and eye closing के लिए you are gonna use the orbicularis. Then coming to the sequence of muscle, which is very very important to remember कि कौन सा muscle कहाँ पे. If you are able to understand this logic ना, you will be able to solve the question, ठीक है. Now I'll tell you very simple part first. So medial rectus is present medially, lateral rectus is present laterally. खत्म हो गई बात, चलो ये muscle clear हो गए 4. What about the inferior rectus? On the lateral side you will see there is an inferior rectus, and medially to the inferior rectus there is gonna be superior oblique. एक ये लाइन अगर आपने याद कर ली तो आपको मसल के पैटर्न में कोई दिक्कत नहीं आएगी. अगेन आई वांट टू रिपीट, सर inferior rectus प्रेजेंट होता है lateral साइड पे, उसके जस्ट बगल में आपका प्रेजेंट होता है superior oblique. So opposite would happen on the top notch area. So inferior rectus is here, here is gonna be superior rectus, and adjacent to superior rectus there is gonna be inferior oblique, and opposite will happen on the opposite high. Again the lateral side पे inferior rectus, middle side पे superior oblique. Now the mnemonicum SO4LR6. So lateral rectus is supplied by 6th nerve, superior oblique is supplied by, lateral rectus is supplied by 6th nerve, and superior oblique is supplied by 4th nerve. Rest everyone is supplied by 3rd nerve, 3rd nerve, 3rd nerve, 3rd nerve, 3rd nerve. So this was the whole funda behind this. I'll tell you some sequence to remember the individual functioning of these muscles. So let's see this area now along with me. Sir, पहले तो आपने दिमाग में ये इमेज बनानी, SRIR SOIO. SRIR means superior rectus, inferior rectus, superior oblique, inferior oblique. Now you will read pattern along with me and this will become cakewalk for all of you. पहला पैटर्न रीड करना है. पहला पैटर्न इज सेइंग in X in X. पहला पैटर्न इज सेइंग SRIR SOIO. Along with that in X in X. And now the next pattern is gonna be add abduct abduct. Next pattern is gonna be add abduct abduct. Then the third pattern is gonna be elevation depression depression elevation. Now you will get the individual muscle function: superior rectus, inferior rectus, superior oblique and inferior oblique. This is how beautifully you are going to remember for your exam. SRIR SOIO, in X in X, add abduct abduct, elevation depression depression elevation. This is how beautifully you are going to remember the individual muscle function. कौन सा नर्व सप्लाई करता है, आँख खोलने में कौन सा हेल्प करता है, बंद करने में कौन सा हेल्प करता है. सो एवरीथिंग इज क्रिस्टल एंड क्रियल. Now sir, we are having two eyes, then how we are able to see only one image? How this is possible? So this is binocular single vision divided into 3 grades. What are these 3 grades? Grade 1 is simultaneous macular perception. Grade 2 is gonna be your fusion of the 2 images, and grade 3 is gonna be your 3D depth of the perception. So grade 2 is fusion, where you're gonna see only 2D image. Depth perception is very very important. If you're not having the depth perception, you will not be able to figure out how far the object is. So for that we are having one more test, and that test is gonna be coming in your exam. That is your titmus flight test. That's gonna be what's your टिटमस फ्लाइटस. So binocular single vision 3 grade भाई. सबसे पहले simultaneous macular perception, second is gonna be your fusion, and third is gonna be your stereopsis. Done. Coming on to the next, anisometropia. Sir, if your power difference between two eyes are more than 2 standard deviation, दो आंखों के बीच का difference more than 2 standard deviation, before that know that 1 standard deviation is equal to 68%, 2 standard deviation is equal to 95%, 3 standard deviation is equal to 99%. That is area under curve. कि इतना एरिया कवर करा, तो दोनों के बीच में जो डिफरेंस है 2 स्टैंडर्ड डिविएशन से ज़्यादा, मतलब 95% से ज़्यादा डिफरेंस है. They can't wear glasses and they will be having a complication called as what's your diplopia. But the treatment of choice here in the anisometropia is gonna be your contact lens. It's gonna be your contact lens, and this was also your exam का question. तो इससे पहले हमने पढ़ा था monochromaticism. So can anyone tell me in the chat box what is monochromaticism? What is monochromaticism? Then coming on to the next one is called as what's your cataract. Next one is called as what's your cataract. The opacification of the lens is called as cataract. Most common cause of blindness, one liner पढ़ लो सर सारे के सारे. Yes, important one liners. Most common cause of blindness, cataract. Second most common cause of blindness is gonna be glaucoma. Most infectious cause is trachoma. In children, vitamin A, and ocular morbidity, that is gonna be your refractive errors like miosis, mydriasis. Done. Very good Sonia. Very good Kajal, Dr. Diary, Ankita Jha, Ajhu. Very good everyone. Chalo. Now let's move on to the according to WHO. What is blindness? Less than 3/60. With the best possible correction, if it is there, we will consider that as blindness. This is a proper definition of blindness asked twice in the FMGE exam. Now type of blindness is there. So mnemonic is ESM. Like we study a subject called as PSM, here you have to remember the ESM. My dear friends, E stands for economic, S stands for social, M stands for manifest, and this is gonna be very simple. Less than 6/60, 3/60, 1/60. तो pattern है 6/60, 3/60 and 1/60. If I ask what about the 2/60, that's gonna be coming under which? The question is, if a blindness is 2/60, number आ रहा है आँख का 2/60, this is in which category? Economic, social or manifest? Can you please answer me? This is gonna be social because it is less than 3 and more than 1. Less than 3 and more than 1. Less than 3 and more than 1. Done. Now gonna be your next topic called as cataract. ठीक है सर, हमने पढ़ ली अभी तक नॉर्मल एनाटमी पढ़ ली, ब्लड सप्लाई पढ़ ली सर, हमने विजुअल फील्ड के बारे में पढ़ा, हमने कलर ब्लाइंडनेस के बारे में पढ़ा, हमने विजन के बारे में पढ़ा. नाउ वी आर गोइंग टू टॉक अबाउट द वेरी ब्यूटीफुल टॉपिक दैट इज कॉल्ड एज योर कैटरैक्ट. Nuclear, cortical and posterior subcapsular. Nuclear is for the day blindness, cortical is for the night blindness, and posterior subcapsular is for day and night, plus near vision is impaired. Now you will tell me something, sir. A bright daylight के अंदर old person is not able to read newspaper. Out of these three, which is type of blindness he is gonna have? Bright daylight के अंदर there is gonna be old person, he is not able to read the newspaper. Then it's gonna be what type of cataract? That's gonna be what type of cataract? One hint is newspaper, that is near vision, another is bright daylight. So both these are coming under the category of posterior subcapsular cataract. Posterior subcapsular cataract. Done. Then coming to the zonular, laminar or Ryder's cataracts, you can see the spokes wheel opacity right here, sir. We can very well identify the spokes wheel opacity. Then coming to the punctate and blue dot cataract, you can see this punctate or dots you can see. These two are what, sir? Your congenital cataract. Then traumatic के अंदर you are going to see in the blunt trauma, this is called as flower shape roseate cataract. Flower shape roseate cataract is there. Then metabolic is important, that is diabetic. So all the cataracts are na very slow developing, painless, but only cataract which is sudden, that is gonna be your diabetic, and you're gonna see the sorbitol and fructose accumulation right here, sir. Sorbitol and fructose accumulation right here. This was also your previous year question कि भैया इसमें जमा क्या हो रखा होता है. Then your answer is gonna be sorbitol and fructose. Now Wilson's disease. There is a deficiency of ceruloplasmin. Because of the deficiency of ceruloplasmin, the copper is not transported from one area to the another area. So copper get deposited into the different part of the body. So now we have to talk about only the eye. In eye, it will be settled, and this is gonna be your Kesher-Flesch's ring. And also this can go to the brain, so there will be a CNS changes, there will be a confusion, there will be a hepatosplenomegaly, intentional tremors, there can be a seizure also. So this Wilson's disease is important as per the case in the exam, and this is gonna be ATP7B. B for Wilson, B for Wilson. So this is how you are gonna remember the Wilson's disease for the exam. Now coming to the next one is galactosemia. Galactosemia, you are gonna see oil drop cataract. You can beautifully see right here. And also the enzyme deficiency is Gal-put. Along with the Gal-put, you have to remember the breastfeeding is contraindicated. The breastfeeding is what, sir? Your contraindicated. Then coming to the fourth one is myotonic dystrophica. Here you are going to see a Christmas tree appearance. These are the one-liner previous year question which were covered, and we are going to do it done, 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 done. Then coming to the no. Then this question came last to last exam. The history was like this: कि patient is working in a iron ka factory, and the patient is working in the iron factory came to you with the matty deposition in the eye. What is this? This is gonna be your iron, and the fancy name which we were using for this is gonna be siderosis bulbi. Siderosis bulbi was exact option which was given in your exam, and that was how you have to mark it. And remember, the treatment to this is we have to remove it with the help of the needle, 26 gauge needle. Foreign body आंख से निकालने के लिए the smallest bore needle is we are going to use is a 26 gauge का needle. These are all done. Then coming to the symptoms of the cataract, as I told you, there are the slow, painless loss of vision. The only cataract which is sudden cataract is gonna be your diabetic or snowflake cataract, where sorbitol and fructose is deposited. Along with that, you are going to see the diplopia and polyopia. Along with that, you are going to see the color halos. Can you tell me the name of the test which is used to check the color halos? The name of the test which is used to check the color halos is gonna be your Fincham test. Fincham test. This is the Fincham test going to help you. Now this is slit lamp examination. You can very well see for the cataract patient, the slit lamp examination is very, very important. So here you can see one unhappy man, and after that unhappy man, there is a very happy woman. So this odd combo image you have to remember for your exam, and she is checking her eyes whether there is a opacity or not, because opacity is something which you're gonna see in the cataract. The treatment of the cataract depends whether the patient is your young patient or old patient. So my dear friends, if young patient is there, will not go for the surgery, because we need accommodation. We need what, sir? Accommodation. But in the old patient, what we can do? We can directly go for the surgical removal. Now the topic comes, what are the type of surgeries, sir, we have to remember for the exam? So 4 to 5 types of surgeries I'm gonna explain you. After that, I'm gonna explain you what are the complications which can happen after the surgery, and we are good with the topic called as cataract. All the topics which are needed to study before the exam in cataract will be covering in another 3 minutes. Now coming to the number one is intracapsular cataract extraction, sir. Intracapsular cataract extraction, remember, the indication is subluxated or dislocated cataract, where the lens plus capsule both are removed. Lens भी हटा देते हैं, capsule भी हटा देते हैं. This is gonna be your intracapsular cataract extraction. Then coming to the extracapsular cataract extraction. Here capsule is in situ but the lens is removed, and indication for this is gonna be only hard cataract, and the intraocular lens is placed inside. And remember, the vision which we are getting back in extra capsule is gonna be 6/18, 6/18, 6/18. Yes. Now coming to the third one is phacoemulsification. This is a stitchless surgery. Why stitchless surgery is there? Because the incision given is only 3 mm. And if 3 mm incision is given, how the lens can come out? The lens can come out only if the lens is, what's here? Liquefied, or you can say the soft cataract. Soft cataract. So only soft cataract can come outside from such a small opening of 3 mm. And such small opening of 3 mm we don't need to close. For that we don't put suture. because of not putting suture, we are getting the vision back is 6/6. So phaco is giving us better vision as compared to the extracapsular cataract extraction because there is a stitch less surgery. Now the fourth one is flask. Flask is femto assisted cataract surgery, which is advanced surgery, best among all the cataract surgical procedure. So intracapsular cataract extraction, extracapsular cataract extraction, phacoemulsification and flax. The best is gonna be your flax because this is the procedure with the latest guidelines we are doing in the ophthalmology. Now coming to the post-op complication, we have studied different type of cataract. We have studied the symptoms. We have studied how to diagnose it. We have studied what surgeries we do, and now the surgery is done. What about the complication? The complication part number one is secondary cataract. How you are gonna check whether there is a secondary cataract or not? There is gonna be Elshing pearl and sommering. Elshing pearl and sommering. Now treatment for these two are what your ND-YACA laser. Then cystoid macular edema. There will be edema in the macula. You will see the layer. Edema is there because of this. There will be a metamorphism. There will be a metamorphism, that means distorted images you are going to see. Plus on fundoscopy you can appreciate there is a honeycomb crusting. There is what, sir? Your honeycomb crusting. So remember, honeycomb crusting associated with the diabetes, cystoid macular edema. So two things are there. One is secondary cataract, another is your cystoid macular edema, and third one is gonna be your endophthalmitis. The endophthalmitis is gonna be the infection of the vitreous, and the loss of infection is within 72 hours. First V is vitreous, second V is loss of vision. Drug of choice is intravitreal vancomycin. So this is a 4V disease. So every disease you have studied maybe 3D, 2D, but now your endophthalmitis is gonna be your 4V disease, and that was your last exam ka question. So these are the three important complications you have studied along with the what's your cataract. So cataract topic is done. Okay. So now I'm gonna ask you the questions from the cataracts. Sir, cataract ke andar, which is the investigation of choice? Number one question is, in cataract, what is the investigation of choice? Cataract mein, what is gonna be your investigation of choice, sir? Cataract mein, what is gonna be your investigation of choice? The investigation of choice in cataract is gonna be slit lamp examination. Chalo. The next topic which we are going to, yes, Dr. Dia, very nice. So uveitis. So there is a structure called as uvea. If there is an inflammation in that, that is gonna be your uveitis. And remember the mnemonic ICC, that is gonna be your iris, ciliary body, and choroid. Iris decide the color of the body, color of the eyes. Ciliary body is having a role in the aqueous humor ka production. Choroid is the most vascular structure, drained by vortex bone and helps in the thermoregulation. We have revised it well. Now, sir, anterior uveitis, intermediate and posterior uveitis. Out of these three uveitis, which uveitis is painful? Only anterior uveitis is painful. Rest two uveitis are painless. So remember, pain due to ciliary spasm is there. Pars plicata is involved. Most common causes idiopathic. Second is HLA-B27. HLA-B27 I have taught you in 5-in-1 short session also. Others are Retar syndrome or reactive arthritis, which you have to remember with the help of mnemonic called as CUR. CUR is conjunctivitis, urethritis, and arthritis. Conjunctivitis, urethritis, and arthritis. Symptoms are painful loss of vision. There is a redness, and signs you are going to see. There is a redness, pain because of the ciliary muscle congestion. So you will see ciliary congestion is there. Then you will see the flares are there. Then you will see mutton fat capes, and important one is iris nodule. So iris nodules are of two types, copies and busaka. If they are present at the surface, they are the busakas. If they are present at the margin, this is called as copies. If they are present at the margin, this is called as copies. Present at the surface, this is called as busakas. Then another complication which can happen in the anterior uveitis is gonna be your synecdoche formation. So anterior synecdoche formation is Anterior synecdoche formation will lead to A for A, that is angle closure glaucoma, and posterior synecdoche will lead to cataract, plus one more complication which is associated with the posterior synecdoche, that is going to be your festooned pupil. You can see the distorted shape of the pupil right here, sir. This is going to be your festooned pupil. This is going to be your festooned pupil. Done, 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 done. Drug of choice, topical steroid. Very good, sir. Then drug of choice to acute uveitis is gonna be your cycloplegic. Now cycloplegic drug of choice in children is gonna be your atropine, and in adult this is gonna be a cyclopentolate. This is gonna be a cyclopentolate. This is gonna be your cyclopentolate. This is how you have to remember for your exam. Then coming to the intermediate uveitis. पहले तो एंटीरियर यूवीआइटिस पेनफुल था, अब इंटरमीडिएट एंड पोस्टीरियर यूवीआइटिस वो जो है हमारे पेनलेस है. Now intermediate uveitis is involvement of pars plana and plicata, vitreous. And most common cause is again idiopathic, and second most common cause is sarcoidosis. Now most common finding is flutus. In the anterior uveitis there were the flare. Now other finding is snowball, and if many balls are collected together they will form the bank, sir. They will form the bank. Now loss of vision is there. Yes, loss of vision is there, but painless. And treatment में what we are going to do, the steroid injection like triamcinolone. Done, done, done. Now posterior uveitis can be infectious, non-infectious causes will be there. Infectious may we can have a toxoplasmosis also. Non-infectious may sarcoidosis, loss of vision again, but painless loss of vision is there. On examination, two important findings you will see in the posterior uveitis. One is chorioretinitis. Chorioretinitis is a creamy yellow patches. You can very well appreciate on my head, creamy yellow patches, and next is headlight in fog appearance. So these are the two findings you are gonna see in the posterior uveitis, and treatment is antimicrobial for the infectious, toxoplasmosis ke liye pyramycin, and for the non-infectious we are giving the systemic steroid. Now time for some questions from the uveitis. So question number 1 coming from the uveitis. Sir, snow ball and snow bank you will see where? Snow ball and snow bank, where you gonna see? कौन से uveitis के अंदर देखने मिलेगा snow ball and snow bank? Which uveitis you are gonna see snow ball and snow banks? Viraj, very good. This is gonna be your intermediate. Only cataract which is painful. Only cataract which is painful. Only cataract which is painful is gonna be. Only cataract which is painful is gonna be anterior. Very good. Sir, copies and busakas are part of which? Copies and busakas are part of. Copies and busakas are part of. Copies and busakas are part of. Copies and very good. Very good. Sir, chorioretinitis is a feature of. Chorioretinitis is a feature of. Chorioretinitis is a feature of. Next question. Chorioretinitis is a feature of. And posterior uveitis. The treatment of intermediate uveitis. My next question is treatment of intermediate uveitis. Treatment of intermediate uveitis would be. Treatment of intermediate uveitis would be. Treatment of intermediate uveitis would be steroid infection. Treatment of acute anterior uveitis would be. Treatment of acute anterior uveitis would be. Acute anterior uveitis would be. Yes, the answer is cycloplegic drugs. The answer is what, sir? Cycloplegic drug. So comfortably we have revised the topic called as your uveitis. इससे पहले we have revised the topic called as cataracts. So all the topics are clear to all of you. Cataract cover हो गया, आपका पहले का विजन क्लियर हो गया सारा का सारा, uveitis क्लियर हो गया, तो comfortable with everything which we are studying. These are the most high yield previous year topic, multiple time asked in the exam, must to revise before the exam. So just 45 minutes के अंदर we have covered almost half of the ophthalmology. Now coming to the next previous year question is ocular HIV. Sir, ocular HIV, the most common manifestation is cotton wool spot and soft exudate. The most common infection that is gonna be your CMV retinitis. The drug of choice that is gonna be your Van-Gan-Cyclovir is better answer than Gan-Cyclovir, and most common tumor which is associated with this is Kaposi sarcoma. The Kaposi sarcoma is caused by HHV8 virus, which is most common vascular tumor in the HIV positive patient. And this is a finding you are going to see the ocular HIV ka patient, sir. This is pizza pie brush fire appearance. Pizza pie or brush fire appearance you are gonna see right here, sir. Then coming to the next one, next topic is called as glaucoma. The glaucoma is also your 100% exam question on 26th of July 2025. My dear friend, may God bless you all. Everyone is going to pass this exam. Now coming to the glaucoma is a second common cause of blindness, we all know, and the intraocular pressure which is increased is more than 21 mmHg, and the intraocular pressure measured with the help of device called as tonometer. And now you will tell me which is the best tonometer. Now you will tell me which is the best tonometer. That's gonna be question for all of you. Okay. Now coming to the diagnosis part, glaucoma, intraocular pressure बढ़ गया, yes, visual field का defect हो गया. My second question is visual field is measured with the help of. So tonometer ka it is your Goldman applantation. What about the visual field? How you are going to measure the visual field is your second question, my dear friend. And also there will be optic disc damage. The third question is what is the diameter of the optic disc. The third question is diameter of the optic disc, my dear friends. Now coming to the congenital glaucoma, which is also called as ophthalmus, triad is there lacrimation, photophobia and blepharospasm. Then adult glaucoma, angle closure and open angle glaucoma is gonna be there. Angle closure glaucoma is most commonly seen in the female, and open angle glaucoma, no gender predisposition, but let's see male more than female. तो फीमेल का आंखें कैसी होती है, छोटी छोटी होती है, छोटी आंखों में दिक्कत होती है, पास का नहीं दिखता है, दूर का दिखता है. तो फीमेल इज हैविंग स्मॉल आईज hypermetropic. Female is so fond of colors, that is why color halos are present, and people who are like making fake IDs to text female, so remember they are gonna block it. So this is gonna be your pupillary block. This is gonna be what's your pupillary block. So pupillary block is a region for the angle closure glaucoma. And on the other hand, if males are more, male ka eyes bada, that is myopic eyes, and open area mein races are there, color races are present, and here the reason is trabecular fibrosis. So pupillary block is a reason for the angle closure glaucoma, and open angle glaucoma ke liye you are having the trabecular fibrosis. Color races are the part of open angle, and color halos are the part of angle closure glaucoma. That's going to be angle closure glaucoma. If we compare the symptoms, my dear friends, symptoms are pain, redness, sudden loss of vision, and stony hard eye, shallow anterior chamber and steamy cornea. They are the feature of angle closure glaucoma. रट्टा मार लो, exam question के अंदर आएगा. Then asymptomatic tunnel vision. Patient will be complaining, डॉक्टर साहब पहले तो इधर से दिखना बंद हुआ, धीरे ऐसा लगता है जैसे मैं दूरबीन से देख रहा हूँ या टनल को देख रहा हूँ. That is one indicator that he might be having open angle glaucoma. Plus, there is a frequent change in the presbyopic glasses. So these are the two things. Then for the color halos, we are doing test called as Fincham test. That is why Fincham test is coming under the heading of an angle closure glaucoma. Drug of choice pilocarpine. Pilocarpine will do the meiosis. तो angle closure glaucoma जो हो रखा है वो improve हो जाएगा. Laser iridotomy with the help of anti-YAG का laser. And if it is acute attack, then it's situation that we do the mannitol. The drug of choice in children, sir. Drug of choice children is gonna be dorzolamide and brinzolamide. Brinzola, that is carbonic anhydrase inhibitors, and drug of choice in adult is gonna be your latinopros, and that was your previous year question. And surgery which we are going to do is trabeculoplasty with the help of argan laser. So दोनों का difference is very important. अगर female की बात हो रही होगी तो angle closure, no gender, that is gonna be open angle में आंखें बड़ी और angle closure के अंदर the आंख is gonna be छोटू. Color halos is a part of angle closure, and your color races are the part of your open angle. Then sir, ट्रीटमेंट पार्ट के अंदर योर पाइलोकार्पिन इज गोना बी ड्रग ऑफ चॉइस इन एंगल क्लोजर एंड योर ब्रिंजोला डोर्जोलामाइड इन चिल्ड्रन इन द ओपन एंगल प्लस इन द एडल्ट दैट इज गोना बी योर लेटिनोप्रॉस डन डना डन. देन न्यूवास्कुलर ग्लूकोमा. न्यू वेसल्स कब बनती है? जब वहाँ पे हाइपोक्सिया होता है. सो इन रेटिना देयर इज अ हाइपोक्सिया, वेजफ फैक्टर्स आर एक्टिवेटेड, बिकॉज ऑफ दैट देयर इज अ न्यू vascularization. Most common cause for this is what's are your diabetics. So you have to treat by the two modalities. One is stop the new vascularization by the anti-VEGF drug. What are the anti-VEGF drug we are having? Bevacizumab, that is bevacizumab or ranibizumab. And you have to stop the hypoxia by doing the pan photocoagulation there. This is how you are going to prevent the new vascular. Now coming to the next chapter called as optics. ऑप्टिक्स चैप्टर पे आ चुके हैं. ऑप्टिक्स चैप्टर में वी विल बी लर्निंग अबाउट द मायोपिया, हाइपरमेट्रोपिया, है ना, index myopia. So first of all, if the eye is big, the rays are converging before the retina, so you need a lens which is a diverging lens. Which lens is diverging lens? That is your concave lens. So for the myopic eye, you can see the lens which we are using is what's your concave lens, and 24 mm is the anterior posterior diameter. If it is increasing by 1 mm, the power difference is gonna be that -3 diopters. Same will happen for the opposite part, that is hypermetropia. हाइपरमेट्रोपिया में आपकी रेज जो है वो पीछे फोकस हो रही है, तो यू नीड अ कन्वर्जिंग लेंस, विच इज़ अ कन्वर्जिंग लेंस, दैट इज गोना बी योर कन्वेक्स लेंस. इन कन्वेक्स लेंस योर फोकस विल बी ऑन रेटिना, एंड ईच 1 mm डिक्रीज इन द एंटीरियर पोस्टीरियर डायमीटर विल लीड टू अ पावर डिफरेंस ऑफ +3 डायप्टर. तो कुल मिला के अगर पावर बढ़ रही है तो -3 के हिसाब से चेंज होगा, अगर पावर कम हो रही है, सॉरी लेंथ कम हो रहा है तो +3 के हिसाब से ऑपोजिट विल हैपन. दिस यू हैव टू टेक केयर ऑफ. नाउ कमिंग ऑन टू द मायोपिया, हाइपरमेट्रोपिया. नाउ कमिंग टू द एस्टिग्मेटिज्म. Sir, astigmatism is most common refractory error. There are the two different foci. One is before and another is after the retina. In such situation, you will give the cylindrical or toric lenses. Cylindrical or toric lenses you are going to give. And then coming to the presbyopia, accommodation power is lost along with the age, and in that you will use a bifocal lens. Now coming to the next one, that is your index myopia. Sir, there is with the old age there is a sclerotic changes in the pupil. Pupil if becomes sclerotic, this is gonna be leading to a condition called as index myopia. Now the retina is absolutely normal, most commonly seen in the old age people. Decrease in vision which improves on pinhole test. जब हम पिन होल से देखते हैं वही विजन इंप्रूव हो जाता है जो घट रहा होता है. प्लस देर आर द चेंजेस यू आर गोइंग टू सी इन द न्यूक्लियस ऑफ द लेंस. एंड व्हाट टाइप ऑफ चेंजेस यू आर गोना सी? यू आर गोना सी द स्क्लेरोटिक चेंजेस. यू आर गोना सी व्हाट्स आर योर स्क्लेरोटिक चेंजेस. डन डना डन डना डन. Now we are going to talk about the next topic called as what's are your retina. So retina is having 10 layer, 9 are neurosensory and 10th is pigmentary layer. A retinal detachment question comes many times in the exam. So there are the 9 layers which are separated from the 10th layer which is a pigmented layer, and it comes like पर्दा गिर गया तो कहता है curtain like sensation in front of eye, floaters and flashes are seen. On fundoscopy what you see? Gray glow is seen. Gray glow is seen. If gray glow is there, retinal detachment, red glow is there, मतलब आँख absolutely fine. Now what are the types of retinal detachment we have to study? The types of retinal detachment which you have to study is, one is rhegmatogenous, tractional and exudative. Sir, rhegmatogenous की अगर हम बात करें, rhegmatogenous risk factor is myopia more than trauma, treatment is buckling. That tractional most common cause is diabetic and you have to remove the membrane. Exudative is malignant melanoma of the choroid, which is the overall most common ocular tumor in the adult. So this is how you're gonna repeat this 3 along with me. One is rhegmatogenous retinal detachment, number 1. Second is tractional retinal detachment. Third is exudative retinal detachment. Rhegmatogenous, tractional, exudative, 3 type of retinal detachment. Retinal detachment patient will be coming to you, डॉक्टर साहब मेरी आंखों के सामने एकदम से क्या गिर गया? पर्दा. Now coming to the diabetic retinopathy. So type 1 diabetes में कब होने के चांस रहते हैं, type 2 में कब होने के चांस रहते हैं? So if the person is diagnosed with type 1 which is insulin dependent, if type 1 is there, insulin dependent is there, then you have to see 5 years and check once a year. Then type 2 at the time of diagnosis. The earliest is gonna be your microaneurysm. The earliest is gonna be what, sir? Your microaneurysm. एंड रिमेंबर, ये मैं दोबारा से बता देता हूँ, टाइप 1 अगर डायग्नोस होगा तो 5 साल के बाद सोचना कि आपको डायबिटिक रेटिनोपैथी हो सकती है. If type 2 is there, at the time of diagnosis only you have to check for the diabetic retinopathy. Then earliest feature is microaneurysm, and most specific is gonna be your neovascularization. Now let's talk about this diabetic retinopathy. We're dividing into two parts. One is your non-proliferative, another is your proliferative. By proliferative का मतलब है new blood vessels are present. Non-proliferative का मतलब है कि new blood vessels are not present. So what are the signs you are going to look for the non-proliferative? There's gonna be the soft hard exudate dot blot hemorrhage and flame shape hemorrhage you are going to see. So in the proliferative, new blood vessels are there. If you can see right here, this is proliferative, there is a extra blood vessels. ठीक है. नॉन प्रोलिफरेटिव के अंदर you will not see the extra blood vessels, plus you will see the micro aneurysm प्लस पिन पॉइंट. हिमोरेज नहीं होगा नॉन प्रोलिफरेटिव के अंदर. लेस हिमोरेज विल बी देयर, मोर हिमोरेज का चांसेस विल बी देयर इन द proliferative diabetic retinopathy. For the treatment for both of them, non-proliferative is just retinal photocoagulation, and in the proliferative you have to do the pan-retinocoagulation. Now vitreous hemorrhage, floaters and flashes, both floaters are seen, flashes are absent. Sudden loss of vision, most common in the adult cause is diabetic, young में trauma, second most common in young is Eales disease. No glow is seen on examination. The third type of glow I am teaching you. फर्स्ट टाइप ऑफ ग्लो आई टॉट यू, रेड कलर ग्लो आएगा तो नॉर्मल आई होगा, ग्रे कलर का होगा तो देयर इज गोना बी द retinal detachment. And now coming to the no glow. The no glow is gonna be seen in the vitreous hemorrhage. If a patient is coming to you with a vitreous hemorrhage, the treatment is bed rest for the 3 months and treatment is vitrectomy after 3 months if it is not resolved. This is a condition which will get resolved in 3 months. If not getting resolved in 3 months, the treatment is vitrectomy. The treatment is what, sir? Vitrectomy. Now coming to these two, out of these two, one is gonna be coming in your exam on 26th of July 2025. एक क्वेश्चन तो गारंटी के साथ इन दोनों में से आएगा आपके एग्जाम में. Now coming to the tomato splash appearance, you will see in central retinal venous occlusion. Plus this is associated with 100th day of glaucoma. So my dear friends, the loss of most common cause of loss of vision is macular edema in this, and anti-VEGF drug like Bewafa Rani you have to give, sir. Then CRAO, central retinal atrial occlusion. You can see the cherry red spot, number 1. Second is boxcar appearance. Boxcar appearance, cherry red color points are there. Then irreversible if not treated within 4 hours. And how you'll give a treatment? Ocular massage and decrease intraocular pressure by the mannitol. Decrease intraocular pressure by the mannitol. Then coming to the retinitis pigmentosa. Sir, रात को नहीं दिखाई देता is sounding like a retinitis pigmentosa. Now tried off. रात को कौन आता है? पापा. पापा को हिंदी में बोलते हैं बाप. तो रिमेंबर द रात का ट्राइड इज बाप ट्राइड. B stands for bone spicule, A for atriolar attenuation, P for pale waxy disc. Gold standard examination is going to be your electroretinography, and patient can't be treated but can be delayed. So how to delay it? Delays with the help of vitamin A, that is 15,000 international unit per day. Done. Then coming to the another previous year question, multiple time asked question of the exam, that is gonna be your retinoblastoma. It's the most common ocular tumor in the childhood. Which gene? RB1. Which chromosome? 13q14. And you will see the cat eye pupil right here. First thing is. Second is you will see the cottage cheese appearance. And third thing, you are going to see the flexner vincent rosette. So ये तीन important finding, cottage cheese and leukocoria, that is going to be a cat eye pupil. Important finding of retinoblastoma. Retinoblastoma, the primary aim is to save the life because it can metastasize to the brain and person can die. The most common of death, cause of death is metastasis to the brain. Second is save the eye, and third is your save the vision. Done. चलो जी, बहुत बढ़िया. इसी लगन से मेहनत से रिवीजन करेंगे, सबका बेड़ा पार हो जाएगा और सबके सब पासिंग सर्टिफिकेट लेके आएंगे. चलिए सर, कॉर्निया एंड कंजक्टिवा. So there is gonna be 3 layers: lipid, aqueous, and mucin. In short, they are lubricating the eye. If they are absent, the eye is gonna be dry. Khatam. Now lipid layer is from the meibomian gland, aqueous is from the lacrimal gland, and mucin is from the goblet cell. They secrete the goblet cells. Now, dry eyes or keratoconjunctivitis sicca, where there is an absence of aqueous, lipid, or mucin layer. Okay? Now, when there is an absence of these layers, there will be dryness in the eye. Mostly this is seen in the old age group. They'll be complaining कि मेरी आंख में कुछ गिरा हुआ है, foreign body like sensation, आंख में दर्द हो रहा है, can't tolerate fan and AC, can't tolerate fan and AC, and symptoms worsen at night. Symptom worsen at night. Now how to diagnose it, sir? Rose Bengal dye is positive. Tear breakup time is less than 10 seconds. That is also called as Schimmer's test. Schimmer's test. And treatment के अंदर you have to give the lubricants like the methyl cellulose. Lubricants like the methyl cellulose. Then it's gonna be the best way to remove the corneal foreign body. That is going to be the 26 gauge needle that we have already discussed. Ophthalmia, different grading. Let's revise them. 1 1 1 1 1 1 1. XN is gonna be your night blindness. X1 is a long name, that is conjunctival. XB is bitot. 2 is conjunctival. 3A and 3B. 3 is corneal ulcer involving less than 1/3 of the area, and corneal ulcer involving more than 1/3 is gonna be 3B. Then S and F. S is gonna be corneal scar, F is gonna be xerophthalmic fundus, and treatment to all this condition is what's your vitamin A. If there is a deficiency of vitamin A, you are going to see the MCQ simplest one, that is your white dot spot. Now coming to next one is conjunctival degeneration, peningula and pterygium. Peningula is a fatty degeneration. Fatty degeneration that will lead to bumper type of appearance, and pterygium is gonna be bird wing like flap. Sir, if asymptomatic, no treatment. If symptomatic, you have to do the excision of this flap. Excision of this flap. Coming on to the next topic in the ophthalmology, that is gonna be conjunctivitis. Most common is viral conjunctivitis. Now there are the different type of conjunctivitis we have to study. Number one is epidemic keratoconjunctivitis, which is also called as pink eye, madras eye, shipyard eye. Caused by viral is most common. That is why remember adenovirus. Adenovirus का shape कैसा है? Space vehicle shape है. Most infectious and spreads very very fast. Then coming to the acute hemorrhagic conjunctivitis caused by the Apollo virus and enterovirus 70. Apollo hospital जाते हैं जब हमें चोट लग जाती, तो hemorrhagic will be your Apollo virus and EV70. Then coming to the ophthalmia neonatum, very important. Conjunctivitis happening within 30 days of the birth. So first 24 hour में who is responsible, 3 to 5 days में who is responsible, and 5 to 15 days या 14 days में who is responsible. So my dear friends, within 24 hour chemical conjunctivitis by the silver nitrate, then Neisseria gonorrhea, then chlamydia trachomatis. 24 hours के अंदर there's gonna be your silver nitrate, 3 to 5 days Neisseria gonorrhea, 5 to 14 days chlamydia trachomatis, and next the chlamydia trachomatis is causing disease called as what's your trachoma. So trachoma is the most infectious cause of the blindness, and triad what you're gonna see is redness, watering, and photophobia. And hallmarks are very very important. The number one hallmark you're going to see is what's sago grain follicles. You can see right here, sir, साबूदाने जैसा. Then you are going to appreciate this Harbut pit, sir. ये देखो ऐसे गड्ढे पड़े हुए हैं, ये गड्ढा पड़ा हुआ है, ये गड्ढा पड़ा. This is called the Harbut pits, and because of the scarring, you are going to see the Arls line. This is Arls line. You're going to see gonna be your Arls line, sir. Now treatment part is safe strategy. We all know this safe strategy is for surgery. Drug of choice is azithromycin. Face के ऊपर facial hygiene and environmental sanitization. How we can prevent from spreading? By the help of blanket therapy, that is 1% tetracycline का ointment. WHO grading is going to be the FISTO. F stands for follicles. Which follicle we are talking about? Sago grain follicle. I stands for infection. S for scarring. Because of scarring, Arls line infection is called by chlamydia trachomatis. Plus T for trichiasis. What do you mean by trichiasis? That is your misdirected eyelashes. And O stands for opacities. O stands for opacities. Okay, chalo. Now coming spring cataract and vernal keratoconjunctivitis, very active. Dr. Dairy है, dairy नहीं है भैया. So spring cataract and vernal keratoconjunctivitis. This is kind of an allergic condition. The allergic condition, remember there is a cobblestone papillae, Taranta spot, cobblestone papillae, shield ulcer, ropey discharge. So this is all coming under vernal keratoconjunctivitis. एलर्जी कंडीशन है तो ट्रीटमेंट भी कुछ ऐसा ही देंगे, सोडियम क्रोमोग्लाइकेट, that is your mast cell stabilizers. That's gonna be mast cell stabilizer plus you're gonna add what's it, a topical steroid. Next is giant papillary conjunctivitis. Sir, giant papillary conjunctivitis mostly seen with the misuse of the contact lenses. अब giant नाम ही लिखा है तो यहाँ पे जो अपीयरेंस है वो बहुत बड़ी बड़ी है. अब कॉबल स्टोन का साइज बहुत बड़ा हो गया तो giant papillary conjunctivitis we get confused in exam. तो कॉन्टैक्ट लेंस का हिस्ट्री है, बड़े बड़े पेबल स्टोन यहाँ पे दिख रहे, कॉबल स्टोन यहाँ पे दिख रहे, दिस इज गोना बी जीपीसी. जीपीसी का ट्रीटमेंट इज एक्सीजन सर्जिकल रिमूवल एंड हेयर फॉर द स्प्रिंग कैटरैक्ट वी हैव टू रिमूव द triggering factor, that's gonna be the allergy. So sodium chromoglycate and steroid we use, and done. Then gonna be your next topic called as cornea. Cornea has 5 layers, no matters what, but corneal donation is important. So HLA matching is required or not required for this? HLA matching is not required, must done within 6 hours. Preservation of cornea is also your previous year question. भाई cornea तो निकाल लिया 6 घंटे के अंदर अंदर, अब रखा कहाँ? तो रखने के लिए there are the 2 medias, one is Macquarie-Kaufman media and other is Optisol GS. Macquarie-Kaufman can store for 26 hours and Optisol GS will save for 14 hours. Now what is the normal cell count and how much it is required minimal to do it, donation? So normal cell count in a cornea is 3000 cells per millimeter of squares. For donation at least you require 2000. And what are the contraindication? From where you don't have to take it. You don't have to take from the HIV positive, HSV and hepatitis B वाले बंदे से नहीं लेना है. Corneal ulcers. Number 1, very famous acantha amoeba keratitis seen in the contact lens users, and this is caused by the pseudomonas, and you will see this is the most painful ring shaped ulcer you will see caused by the pseudomonas. This is called as acantha amoeba. Multiple time question asked in your exam. Second is bacterial. In the world it is caused by Staph aureus and in India is called by Staph pneumoniae. Drug of choice is 4th generation fluoroquinolones. How you are gonna see? The hypopyon here is not fixed. The spreaded hypopyon is feature of bacterial keratitis. Then is gonna be very famous fungal caused by aspergillus. Finger-like projections are there. Feathery margins are there, satellite lesions are there, plus you can see the hypopyon which is fixed. Now this hypopyon is fixed, that is fungal, F for fungal, F for fixed, and if it is spreaded either udar, that is your bacterial, that is gonna be your bacterial. Treatment here is gonna be your natamycin. Then HSV, dendritic or geographical ulcer caused by HSV1, antiviral therapy we have to give. अगर कोई आपका अल्सर हील नहीं कर रहा हो then keratoplasty, and also if the perforation is very small 0.1 mm then we can use a glue called as cyanoacrylate glue. Then if there is a thinning of the corneal mid surface of the corneal, then the condition is gonna be keratoconus. Sign you are going to get is Munson, Fleischer, Bogart. Treatment में देख लेना आप. सबसे पहले we try to put the glasses से आराम नहीं आएगा, RPG lens से भी नहीं आएगा, then we have to go for the keratoplasty. तो glass, RPG lens, keratoplasty is going to be the last. If someone is having keratoconus, the LASIK का surgery is not done in that person. The only contraindication for the refractive surgery is keratoconus. Is gonna be what's your keratoconus, and LASIK stands for laser assisted in situ keratomiliosis, a very famous surgery to correct the refractive error, and refractive error we all have studied in the chapter of optics. Now, optic neuritis also called as papillitis, inflammation of the optic nerve का inflammation हो गया. कारण क्या है इसका सर? multiple sclerosis. A pain occur with the ocular movement is seen. जैसे जैसे आप घुमा रहे हो वैसे वैसे दर्द हो रही है. ट्रीटमेंट के लिए आप इंट्रा स्टीरॉयड का इंजेक्शन देगो, प्रेडनिसिलोन. देन कमिंग रेट्रोबल्बर न्यूराइटिस. अब न्यूराइटिस बिहाइंड ऑप्टिक डिस्क के पीछे हुआ तो भाई एक तो पेशेंट ब्लाइंड हो गया, दूसरा डॉक्टर को नहीं दिख रहा, तो डॉक्टर एंड पेशेंट बोथ आर ब्लाइंड. ट्रीटमेंट इज IV मिथाइल प्रेडनिसोलोन इन बोथ ऑफ देम. टॉक्सिक एम्ब्लॉयपिया, लेजी आई बिकॉज ऑफ द टॉक्सिन. सो स्मोकिंग, अल्कोहल एटसेट्रा कैन लीड टू अ लेजी आई. ट्रीटमेंट इज विटामिन B12 प्लस स्टॉप स्मोकिंग एंड स्टॉप द अल्कोहल. These two very important. Argyle Robertson and your prostitute pupil. Argyle Robertson, which is also called as prostitute pupil, you can see this is associated with neurosyphilis. Pinpoint pupil is there. Accommodation power is present. Pupillary reflex is absent. Accommodation present, pupillary reflex plus constricted pupil is gonna be your prostitute pupil. If the pupil is gonna be dilated pupil plus accommodation power is present, pupillary reflex is absent, this is gonna be your AD stonic pupil. So दोनों में एक ही difference है pupil का. If pupil is constricted along with the accommodation power present, corneal reflex absent, gonna be Argyll Robertson. If pupil is dilated along with the accommodation power present, pupillary reflex absent, that's gonna be your AD stonic pupil. That's gonna be your AD stonic pupil. Now in AD stonic pupil, one thing more you have to remember is a pilocarpine ka test. Pilocarpine will do what's a meiosis. If we put pilocarpine, the normal eye will become constricted and abnormal will become of a normal size. This is how we are going to test this. Next thing is Horner syndrome. Horner syndrome ka mnemonic is female. P for ptosis, meiosis and hydrosis, loss of ciliospinary reflex and anophthalmos. So these are the 5, 1, 2, 3, 4, 5. So remember ptosis, meiosis and hydrosis, loss of ciliospinal reflex and anhydrosis. Here the diagnosis is Coquine test. So normal eye, the eye will dilate. So Coquine is a pupil dilator. Coquine is a pupil dilator. So abnormal eye will become normal. So pilocarpine उसको छोटा करेगी. Pilocarpine is test for adystonic pupil and this Coquine is test for the Horner syndrome. Coming on to the next one called as what's a papilledema. Sir, disc edema. Along with the disc edema, there is a raised intracranial tension, worse headache, projectile vomiting, west headache, projectile vomiting, and then enlargement of a blind spot is seen, but vision is normal. तो papilledema में सारी चीज़ बढ़िया है, विजन नॉर्मल है, बाकी सारी चीज़ खराब हो जा रही है. Drug of choice acetazolamide, which is nothing but your carbonic anhydrase inhibitor, your diuretic. Now coming to the next chapter called as visual field defect. 100% एग्जाम क्वेश्चन आएगा आएगा आएगा, तो इसको भी रिवाइज कर लो. If there is a lesion on the right optic nerve, there is gonna be the right hemianopia. Right hemianopia. If optic chiasma is there, bitemporal heminopia, एक साइड का lateral, दूसरी साइड का lateral. If optic tract lesion is there, there will be a contralateral homonymous heminopia, एक साइड का medial, दूसरी साइड का lateral. ये तीनों तो आपको आते हैं. Now coming to the temporal lobe and parietal lobe के lesion. These days examiners are asking from this topic also. Temporal lobe is the upper side, so remember in the temporal lobe there is a pie in the sky called as supraquadrant anopia. So supraquadrant, one on the lateral side, another on the middle, supraquadrant. Now parietal lobe is पीछे नीचे की तरफ, तो infraquadranopia, infraquadranopia, infraquadranopia. So temporal and parietal lobe is done. And if visual cortex के ऊपर होगा, there will be a macular sparing heminopus heminopia. Done. Coming on to the next topic called as amblyopia. Lazy eye where brain stop working taking signals. So you will try to make your lazy eye work more. For that treatment is your occlusion of the good eye. So this is good eye. इसको बंद कर दो, lazy eye से काम करवाओ, तो इसका brain और eye coordination improve हो जाएगा and patient will start seeing. The second last topic of today's ophthalmology class is gonna be your dark room procedure. The number one thing which we are going to do is that's gonna be your retinoscopy. Retinoscopy is to check the refractive error and the pinhole diameter is 1 mm, distance taken is 1 meter. Now we are dividing this into distant direct and indirect. Distant direct distance is 25. Different type of glows I taught you. If it is normal then red glow is there, retinal detachment में grey glow होता है, vitreous hemorrhage के अंदर no glow होता है, cataract के अंदर black glow is there. So glows are also very important. Then direct ophthalmoscopy. Distance is not fixed. Quality is virtually erect magnified and magnification power is 15x. This was also your exam question. Now indirect ophthalmoscope, distance is arm of a doctor. Magnification is 5x and quality is real inverted and magnified. The last topic of today's ophthalmology class is your instrument. Number one is suture tying or holding intraocular lens का Kalman-McPherson. Kalman-McPherson के अंदर you will see obtuse angle forming edges, plus there is gonna be holes This is gonna be a plucker type of, but a specialized one. This is Kalman's. Next is Chalazion clamp, which is used for incision drainage. Spring holder forceps is gonna be there. Iris forceps is gonna be having tooth, which is also called as tooth forceps. Strabismal muscle hook, इसको मसल खींचने काम आता है. Maddox rod is used for the diagnosis of strabismus. Then your Desmarais retractor, which is a lid adjuster. Then eye speculum is gonna be looking like this. So this is all we have to do in case of 80% of the topics within just 1.5 hours. So not 1.1 hour 15 minutes. This was the agenda of this final lab, which is a Maha rapid revision, a very fast, crisp and concise. You are going to benefit from this class if you have read it once. अब आपने पहले पढ़ा हुआ तो आपको ये सारे टॉपिक्स जल्दी से रिवाइज करने में बहुत काम आएंगे, बिकॉज डेज आर लेस एंड वी हैव टू मोर output we have to get. So for getting that more output, we are doing this in lot of more speed which we have done previously. तो अभी के हिसाब से स्पीड बहुत ज़्यादा रखनी पड़ती है, क्योंकि दिस इज़ वॉट यू हैव टू डू इन योर लास्ट लिव. So I hope ophthalmology is done. Now we will take a short break, and after short break we are going to start with ENT, and we are going to start class at 11:30 a.m. 11:30 a.m. we are going to do the ENT. ठीक है, चलो, see you all, bye bye. Hello, 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 hello. Hello, 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 hello. Am I audible, guys? Chalo. Hello, Ji. Let's start with the class now. And ENT, we are going to complete. ENT, most high scoring subject, I would say, in the exam. Okay. Now let's talk about the nose part first. If you see the nose is having a 1/3 part which is a bony part and 2/3 part which is a cartilaginous part. And this opening of the nose is made up of alar cartilage, lower lateral cartilage, which is also called as what's your alar cartilage. And to check the nasal valve blockage, we have a test called as Cottley's test. We will just laterally pull the cheeks and you see the blockage is gone. That is to check the nasal valve blockage. That is Cottley's test. So here is gonna be your nose is examined on anterior rhinoscopy. What we check the vestibule, we check the mucus, we check the septum, we check the turbinates mainly, any discharge or not there. These are 4 or 5 things we see once we do the anterior rhinoscopy on the nose. So as per your questions, the anatomy of the bone is important. That bony part is the upper 1/3, lateral 2/3 is the cartilaginous part. Then coming to the deformity in this bony part, the number one deformity we see is there called as a saddle's nose. This is called as saddle's nose. The most common cause is trauma, septal surgery, TB, leprosy is there. And this TB, leprosy, they will affect mostly to the TB will affect TB, lupus, leprosy. They will mostly affect the cartilaginous part. That will be responsible for dipping of this nose called as saddle's nose. And treatment is augmentation rhinoplasty, and we required a graft, and graft is taken from the iliac crust. Coming on to the next one is basal cell carcinoma or rodent ulcer. The most common malignancy of external rows, and you can see the rolled out edges. Rodent ulcer. Rolled out edges are there. Now coming on to the rhinophyma, there is a hypertrophy of the sebaceous gland. Because of the hypertrophy, you can see there is an enlargement. And treatment to such condition is CO2, laser excision, and skin grafting. Skin grafting is of 2 types. One is partial thickness and full thickness graft. We are using with the help of knife called as Humphrey's knife. Foreign body is a nose. So you can very well appreciate this is X-ray nose we are doing right here. So remember, this is a unilateral foreign body. There will be a foul smelling mass present, plus epistaxis will be present. Foreign body is mostly unilateral, and to remove foreign body, there is not just a single instrument you can use any instrument to remove the foreign body. Endoscopic removal will be appreciated. Mysis, maggots in the nose or ear, larva of housefly, that is called as cryosomia. Treatment is maggot oil or which is made up of chloroform plus turpentine. Then coming to the nasal bone fracture, the most common fracture of the face is nasal bone fractures. You can see X-ray we have to do immediately. We have to reduce it with the help of forceps called as, on my head, that is Walsham forceps. Then coming to the nasal septum fracture, 2 type of forces there. One is coming from the front, one is coming from the below. The force which is coming from the front is horizontal or Jargeway. The force which is coming from the below is vertical or chevalet fracture. Now you have to use Ash forceps to reduce this. So this image based question of forceps can also come in exam. Then coming to the blowout fracture or orbital blowout fracture, we have studied. The triad is there, anophthalmos, infraorbital anesthesia, and diplopia, which we have studied in the ophthalmology also. And the on CT scan, which sign you are going to see, this is called as teardrop sign. This is called as what's a teardrop sign. आगे बढ़ेंगे sir. Mid face fracture maxilla का. There is a Lee-Fortis classification. Lee-Fort 1 says there is a transverse fracture, 2 says pyramidal fracture, and 3 says craniofacial disjunction is there. CSF leak is not present in these two, but yes, in the third one, CSF leak is present. Now CSF rhinorrhea. CSF rhinorrhea, the most common cause is trauma. You are going to see the target sign. What is target sign? The normal color of CSF is colorless. The normal color of the CSF is colorless, but if it is blood stain, then we call that as what's your target sign, and this is gonna be T for T, that is your traumatic cause. That is gonna be what's your traumatic cause. The most common site of leak is gonna be your cribriform plate, and diagnosis के अंदर we do a beta 2 transferrin estimation test. How to find the site of leak? That is your HRCT skull base. We do to find the site of leak, and treatment mostly is a conservative plus antibiotic. Why we are adding antibiotic right here? Because it can go into the brain and it can cause the meningitis also, sir. Now coming on to the next one, sir, paranasal sinuses. 4 are in number. They are ventilated during the expiration. One is your maxillary sinus. Next is your sphenoid, which is backside, and then is your frontal sinus. Here it is, and ethmoid sinus is there. So frontal, ethmoid, maxillary, and sphenoid. Largest sinus is gonna be your maxillary sinus, which is present by birth. Sphenoid is first radiological evidence at 4 years. Frontal is gonna be 6 years, and ethmoid air cells is gonna be 2 years. Now anterior ethmoid and posterior ethmoid air cells, you have to remember anterior ethmoid air cells we are having what? Anterior ethmoid air cell we are having bulla ethmodalis and agar nasai. Bulla ethmodalis is your constant, the largest in air cell, and agar nasai is the anterior most anterior air cell. Then posterior ethmoid air cell we are having middle meatus. Middle meatus you will see there is a maxillary sinus, frontal sinus, and anterior ethmoid air cells which are draining into the middle meatus. But drainage is very important of a sinuses. If they are not drained, everything will be filled in that sinus, then will lead to a sinusitis. And if there is a blockage of this landmark called as, which is present in middle meatus, which is buoy. Buoy stands for bulla ethmodalis, uncinate, and your ethmoid infundibulum. So my dear friend, friends, remember bulla ethmodalis, uncinate, and ethmoidal infundibulum. If they are getting blocked, they will lead to sinusitis. The next topic is sinusitis. Sinusitis is osteometal complex get blocked. Because of that, there will be inflammation. That is sinusitis. First investigation is X-ray, nasal endoscopy. We do diagnostic nasal endoscopy, which is also called as DNE. Second is your X-ray. In X-ray, we are doing the Waters view. Sir, this Waters view is occipitomental view. This view is done mainly to check. W का उल्टा कर दो तो one maxillary sinus. And if water view is done open mouth, अगर खुले मुंह से करेंगे open mouth, that is mainly to check the sphenoid sinus, which is called as PRS view. So water is for maxillary, खुले मुंह से waters करेंगे, that is called as PRS. PRS is for the sphenoid sinus. PRS is for the sphenoid sinus. Now coming to the best is CECT. पैरानेजल साइनसेस का CECT करा लो. मेडिकल मैनेजमेंट में एंटीबायोटिक प्लस डीकंजेस्टेड वी गिव इन द साइनोसाइटिस. ट्रीटमेंट इज FES. FES stands for functional endoscopic sinus surgery, where we are getting the drainage back. Then sir, coming on to the complication of sinusitis. There's gonna be the pot puffy tumor. There's gonna be what, sir? Pot puffy tumor. This is frontal sinusitis. This is gonna be what, sir? Frontal sinusitis. And this is not a tumor. This is what, sir? Abscess. This is not a tumor. This is gonna be the absent. This is gonna be the okay. Now coming on to the long-term complication of FES. Sir, the long-term complication of the FES is going to be the synecdoche formation. And what is the treatment of synecdoche? That is going to be your mitomycin C. Then what are the tumors of the paranasal sinuses? Most common, the sinus involved is your maxillary followed by your ethmoid. To check the prognosis, remember there is a Ongren's line. You can see this skull ray. Ongren's line is from middle canthus to the angle of mouth. Here you will remember, below this line there's gonna be the good prognosis, above this line this is gonna be a poor prognosis. This is gonna be your poor prognosis. Total maxillectomy would be the treatment, followed by radiotherapy. Nasal polyp, two type. One is anterocoinal, another is ethmoidal. This AC polyp is unilateral benign mass which is spreading from maxillary sinus to the coana. Maxillary sinus से ये coana तक जाता है, and this is benign unilateral mass which lead to hyponasality also. Hyponasal voice also is present there, and this is most commonly, AC polyp is most commonly seen in the adult, and ethmoidal polyp is most commonly seen in the children. So treatment for both of these, anterocoronal polyp treatment is endoscopic removal, ethmoidal polyp topical corticosteroids we will give, sir. Done. Now coming to the central slide, which has been asked in the multiple exams, sir. It is N for nasal polyp, A for asthma, and then next is allergy to NSAIDs, for example your aspirin. Coming on to the next one, that is your mucormycosis. Mucormycosis is fungal infection of the nose, and most common causative organism would be what, sir? Your rhizopus. Rhizopus. And it is most commonly seen in young diabetic HIV positive patient. Now remember, it can go inside the brain also. One culture we can take from here for the diagnosis. The examiner asks कि अगर ये brain के अंदर जा रहा है, how you will diagnose it? Diagnose with the help of MRI, sir. And treatment is amphotericin B, sir. Treatment is what, sir? Amphotericin B, sir. Now rhinitis medicamentosa. Rhinitis medicamentosa means what, sir? Rhinitis medicamentosa means what, sir? Rhinitis medicamentosa, remember, due to the prolonged use of decongestant, you stop this drop and start the steroid nasal spray. Steroid nasal spray. Then coming to the DNS, that is a deviated nasal septum. There's a blockage on the deviated side and the crust formation on the patent side. Inferior turbinate hypertrophy is there, where you will see a mulberry like mass देखने मिलेगा. Plus special type of headache is there, which is called as Sludder's neuralgia. And treatment which we have to do is called as what, sir? Septoplasty. Then septal hematoma, most common cause is trauma. Treatment में aspirate कर दो, ठीक है. Septal perforation cause trauma, yes. Septal surgery, yes. Tertiary syphilis bony part को करेगी, bony septum को करेगी, और cartilaginous septum को TB lupus leprosi. Then coming to the atrophic rhinitis, also called as ozena. Atrophic rhinitis, which is also called as ozena, caused by Klebsiella ozena, most commonly seen in the female. Atrophic turbinate, roomy nasal cavity filled with crush. There will be a nasal blockage, and the merciful anosmia is there, sir. Merciful anosmia is the patient is not getting any smell, but the doctor is getting smell. खुद को बदबू नहीं आ रही, बाकी वालों को आ रही है. Medical management, alkaline nasal douching is there, sodium bicarbonate, sodium borate, and sodium chloride. Sodium bicarbonate, sodium biborate, and sodium chloride, that is alkaline nasal douching. Treatment के अंदर Young's, modified Young, and Latz-Langer operation. These are the operations you have to remember for the exam. Then coming to the next one is called as for the rhinoscleroma, which is also called as woody nose. Rhinoscleroma, which is also called as woody nose, caused by Klebsiella rhinoscleromatis, seen in UP and Rajasthan. Sir, on biopsy, you will see the Russell body and Mikulicz cell. Russell bodies and Mikulicz cell. Treatment tetracycline streptomycin A. Rhinosporiodosis. Very good. And then rhinosporiodosis caused by Rhinosporiodium seabri. ठीक है, pond bathing का history होगा. Mulberry like mass होगा with epistaxis is there. Remember, excision of mass plus electrocautery of the base, followed by the treatment with the help of a drug called as dapsone we give there, sir. Epistaxis, most common area is Little's area, most common artery is sphenopalatine artery. In what is Kieselbach's plexus, which is supplying this little area, is gas. That is greater palatine artery, anterior ethmoid artery, sphenopalatine artery, then superior labial artery. superior greater palatine, anterior ethmoid, sphenopalatine and superior labial artery. Superior labial artery. Pinch the nose for 3 to 5 minutes. नहीं आराम आता, cauterization of little area with AgNO3 नहीं आराम आता है तो anterior posterior nasal packing. Anterior posterior nasal packing, endoscopic ligation of sphenopalatine artery, maxillary artery ligation, external carotid artery ligation, then ethmoidal artery ligation. This completes our first part, that is nose. This completes our first part, that is called as what's your nose. Then coming to the next is throat. Throat के अंदर we are having pharynx, which is spreaded from skull base to C6. Skull base to C6. Skull base to C6. Skull base to C6. Remember, this is nasopharynx, oropharynx and hypopharynx. Nasopharynx, oropharynx and hypopharynx. Nasopharynx, oropharynx. Nasopharynx के अंदर, remember, the important structure you have to remember is adenoid plus eustachian tube. Adenoid and eustachian tube. Adenoid and eustachian tube. Oropharynx के अंदर important thing is tonsil. Important thing is tonsil. Now let's study hypopharynx. Hypopharynx, we are having a pyriform sinus. Hypopharynx, we are having what's that? Pyriform sinus. Then posterior pharyngeal valve and post-cricoid area is there. This is the area which is surrounding the larynx. Now remember, the most common site of malignancy in the hypopharynx is gonna be your pyriform sinus. And if your laryngeal crepitus is absent, which is also called as Murray sign, that means there is a post-cricoid carcinoma. That means what's a post-cricoid carcinoma. Now next, coming to the nasopharynx. Nasopharynx, important thing is adenoid and eustachian tube. अब adenoid is nothing but a collection of lymphoid tissue. आता है, grow करता है, गायब हो जाता है. Remember sir, it's a collection of lymphoid tissue in the nasopharynx. Sir, no capsule, no crypt, no definitive blood supply. No capsule, no crypt, no definitive blood supply. On palpation, there is a bag of warm feeling. Grows up to 6 years, start decreasing at puberty, disappears by 20 years of age. 20 years of age. Then adenoid hypertrophy. एडेनॉइड बड़े हो गए, स्कूल वाले बच्चों में ज़्यादा कॉमनली माउथ ब्रीदिंग से बच्चा आएगा, एडेनॉइड लाइक फेस होगा. एडेनॉइड फेस कैसा होता है? मुंह खुला है, नाक बंद है, हाई पैलेड मालोक्लूशन ऑफ टीथ. इन इंग्लिश आई से नाउ, open mouth, pinch nose, high palate, malocclusion of teeth because of the closure of the nasopharynx. And remember, treatment is adenoidectomy. And in which position you are doing? Rose position. What is the fault in their rose position? There can be atlantoaxial subluxation, which is also called as Grissel syndrome. And patient might can develop neck pain and torticollis due to spasm of paraspinal muscle, sir. Paraspinal. Now coming to the next one, called as what's your angiofibroma. The most common benign tumor of the nasopharynx is angiofibroma. Site of origin is sphenopalatine foramen. Highly vascular and biopsy is contraindicated. There will be which deformities are frog face deformity. Clinical feature is 12 to 15 years old बच्चा होगा, nasal mask होगा, perfuse epistaxis होगा. CCT में you are going to see what's your Holman-Miller sign, which is also called as antral sign. This is a normal floor of the orbit. You will see in this there is an anterior bossing of the floor of the orbit. And remember, the treatment is surgical removal. Nasopharyngeal carcinoma, most commonly it is coming from China because the etiology is Epstein-Barr virus. Site of origin is fossa of Rosenmuller. There will be a unilateral blockage of a eustachian tube that will lead to conductive hearing loss. And here important thing is tortostride, that is NPC, stands for neuralgic pain, palatal palsy and conductive hearing loss. Neuralgic pain, palatal palsy and conductive hearing loss. Treatment is chemoradiation, better answer than radiotherapy. Then coming oropharynx, we are having what's a tonsil. Tonsil has a crypt, capsule and a blood supply. The blood supply is by tonsillar branch of the facial artery and drainage is by paratonsillar vein. Hemorrhage in tonsillectomy, primary is during surgery, reactionary is within 24 hours. How you will treat it? Re-explore it. Treatment of secondary is going to be the IV antibiotics and cause of secondary is going to be your infection. Quinsy stands for paratonsillar abscess. Quinsy stands for what's it? Paratonsillar abscess, collection of pus between tonsil and its bed. Tonsil and its bed. Tonsil. Tonsil and its bed. Tonsil and its bed. So remember, uvula push other side, tonsil pushed medially. There is a throat pain. Quincy के अंदर throat pain, glossopharyngeal nerve is there. Then dysphagia is gonna be. Then trismus is gonna be there because of the medial pterygoid muscle spasm, hot potato voice. Outer neck swelling is absent in the Quincy. But if it is parapharyngeal abscess, all the features are gonna be same. Only the difference is outer neck swelling is gonna be present. Treatment is per oral incision and drainage, interval tonsillectomy. After 6 weeks, you have to do so. Then Quincke's disease, idiopathic edema of the uvula. Yes. Ludwig angina is a mylohyoid muscle ka infection. Per oral, excision and drainage from outside we have to do. And the clinical feature is chin swelling and trismus will be there, sir. Now coming on to the next one is throat, sir. Then coming on to the next one, that is called as throat. Throat के अंदर we are having larynx, and remember larynx is having 3 unpaired and 3 paired cartilages. 3 unpaired and 3 paired cartilages. The unpaired cartilage number 1 is thyroid cartilage, then cricoid, then epiglottis cartilage. Thyroid cartilage is open book-like. In male, the angle is 90 degree. Female, it is 120 degree. It makes an Adam's apple. Adam's apple. Cricoid cartilage is a ring-like structure, and epiglottis cartilage is a leaf-like structure which is covering the vocal cord. Then keratosis larynx. If people are smoking, there will be an epithelium which is getting shredded. To stop that, first of all, quit the smoking. Plus, you have to do the stripping of the vocal cord mucosa. Sir. Then coming puber and the endorphonia. Male having female-like voices, puberphonia. Female having male-like voices called as androphonia. Puberphonia treatment is type 3 thyroplasty. Endorphonia treatment is type 4 thyroplasty. Then we are having supraglottis. Supraglottis may having a false vocal cord and true vocal cord. Inside this false and true vocal cord, there is a saccule. Saccule is also called as oil can of larynx. जो trumpet blower होते हैं, जो बाजा वाजा बताते हैं, इन लोगों के अंदर this is the enlargement of this saccule. So enlargement of saccule, if you see, there will be a condition called as laryngocele. Then coming to the glottis, which is true vocal cord. If you see this glottis, this is gonna be the true vocal cord. I can appreciate for all of you. This is true vocal cord. True vocal cord, remember, if you see this commissure, there's going to be anterior commissure, there's going to be posterior commissure. Plus, there is going to be the muscle intra-arytenoid and thyroarytenoid. This intra-arytenoid and thyroarytenoid muscle, they are the adductor muscle. And if adduction is not proper, that means these muscles are weak. This will lead to a condition called as phonesthenia. Phonesthenia means there is an incomplete closure of the vocal cord, and this will look like a keyhole glottis. Now coming on to the vocal nodules versus polyp. The vocal nodule versus polyp, if you see, the first difference you have to remember, bilateral is nodules, unilateral is polyp. Second thing is causative difference. Singer's nodule, teacher, screamer, that means a person who is shouting, singing, in that vocal nodules are common, and rest everything is okay. What everything is okay? That is your junction, site is junction of 1/3 and posterior 2/3. Harshness of voice is there. And treatment is different now. Microlaryngeal surgery is treatment of vocal cord polyps, and vocal nodule we are doing the voice rest. Then intubation granuloma. Faulty intubation की वजह से posterior 2/3 part पे you will see the granuloma. Treatment is microlaryngeal surgery. Rinke's edema causes smoking. Harshness of voice is there. Stripping of vocal cord mucosa we do. Pediatric and adult larynx का position and the narrows part is very important. Previous year question. Sir, position is C3 C6 high. बच्चे ऊपर रहते हैं high, adult नीचे C3 C6 low. बच्चे सबको पसंद है. पीडियाट्रिक इज सब ग्लॉटिक, सबको प्लस है. एडल्ट इज ग्लॉटिक, narrows part in the larynx. Now coming to the stridor. 3 type of stridor we have to study. One is inspiratory, biphasic and expiratory. Inspiratory stridor, biphasic stridor and expiratory stridor, sir. Sir, inspiratory stridor is happening when the air is coming onto the uppermost structure. Inspiratory stridor, this is supraglottis. Biphasic stridor, that is going to be glottis and subglottis. Expiratory stridor, thoracic trachea and bronchi. Thoracic trachea and bronchi. Thoracic trachea and bronchi. The functional aphonia or hysterical aphonia. A young female coming to you, आवाज़ नहीं आ रही, कफ रिफ्लेक्स चेक करो, पॉजिटिव होगा मतलब उसको साइकेट्रिक इलनेस है, गिव हर साइकोथेरेपी. लेरिंगोमेशिया, भाई सुप्राग्लॉटिस आपका वीक है जिस वजह से इंस्पिरेटरी स्टाइडर है, प्रेजेंट एट फर्स्ट वीक ऑफ बर्थ एंड इट इंक्रीज ऑन क्राइंग. द मदर विल बी कमिंग टू यू कि मेरे बच्चे का तो भाई रोते हुए स्टाइडर बढ़ता है, गंदी आवाज़ आती है. ट्रीटमेंट इज कंजर्वेटिव मैनेजमेंट बिकॉज राइट नाउ योर सुप्राग्लॉटिस इज वीक बट आफ्टर सम डेज इट विल बी एब्सोल्युटली फाइन. मोमेंट इज एब्सोल्युटली फाइन, एनाटॉमिकली ग्रोन fully, then there will be no stridor on crying. Then coming to the pediatrics laryngeal infection, two things you have to remember here. One is acute epiglottis, another is acute laryngotracheobronchitis. This acute epiglottis is called by strep pneumoniae is better answer than H influenza. You are gonna see the thumb sign on X-ray, and on acute laryngotracheobronchitis, which is caused by parainfluenza virus, you are going to see the steeple sign. For both of them, secure airway, then antibiotic, then your steroid, and also bronchodilators are helpful in treatment. Plus one more thing, in acute epiglottis, you are going to see child sitting in bending forward position because that makes him relieve this symptom. This is called as tripod sign. And barking dog-like cough is a feature of acute laryngotracheobronchitis. TB larynx had two signs, turban and mouse nibble appearance. चूहे ने पगड़ी पहनी है. Question directly asked for the exam from this topic. Cancer larynx, if we see glottic, subglottic and supraglottic, we are dividing into glottic, subglottic and supraglottic cancer. What are the tumor staging we are doing right here? So T1, T2, T3, T4. T1 only one structure is involved, T2 more than one structure is involved, T3 vocal cord is fixed, and T4 is invasion of thyroid cartilage. So if T1 iklota one structure is there, laser surgery is gonna be the better answer. If more than one structure is gonna be there, radiotherapy is gonna be better answer. And T3, T4 total laryngectomy followed by the radiotherapy we have to do. Now laryngectomy is done how to produce the voice. The number one method is esophageal voice, which is a poor method of producing voice. Second is electrolarynx. You can see she's using vibrator and then producing voices. Best is tracheoesophageal puncture device we do. So now coming to the tracheostomy. Most common the tracheostomy is done between first, second and the third ring, but if it is cancer larynx, as we seen this total laryngectomy we're doing, the tracheostomy we do in first and second ring. High tracheostomy, this was also your exam question. अगर आपकी ट्यूब फंस जाती है उसको निकालो, नई ट्यूब डालो, reinsert the new tube. Abductor muscle कौन है? Abductor is thyroarytenoid and intrarytenoid. What about the abductor muscle? Posterior cricoarytenoid muscle. Tensor muscle is gonna be cricoid and vocalis. Sensory supply of the larynx. Above vocal cord, internal branch of superior laryngeal nerve. Below vocal cord, that's gonna be recurrent laryngeal nerve. If recurrent laryngeal nerve is gonna be paralyzed, there is gonna be a harshness of voice. Okay. Now coming to the bilateral adductor and the abductor policy. First you will focus on the bilateral abductor policy. Now your recurrent laryngeal nerve is gone and you are not able to abduct it. Abductor policy, you are not able to abduct it. So if you are not able to abduct it, your vocal cord is like this. If your vocal cord is like this, you are gonna have a respiratory distress plus voice is normal, and you have to make it like this. If you are making it like this is becoming 2. So remember, this is type 2 thyroplasty. Now bilateral adductor policy. Remember here both superior laryngeal nerve and superior laryngeal and recurrent laryngeal nerve is gone. Now your vocal cords are like this, they are not able to do like this. If vocal cords are like this, open vocal cord mein there is no voice, that is why the point is written over there is aphonia. Plus open vocal cord, the aspiration content can go, that is called as aspiration pneumonia, and here you have to make it like a 1. So this is type 1 thyroplasty. Now coming on to the next part of the ENT, that is gonna be your ear. So in half an hour we have covered the nose, we have covered the throat. Now within 20-50 minutes we will cover the next topic called as ear. Quick revision is like this only. ठीक है, ऐसे ही हम notes की quick revision करते हैं. This is how beautifully you have to revise and do it with your beautiful notes all the time before the exam. Now ear की बात करेंगे तो pinna develop from first and second arch. There is a 6 hillock of his which fuse together to form a pinna. Your pinna is this part, full part is pinna, having a part called as lobule, helix, antihelix, concha, symba concha. So these are the parts of the pinna. Then external artery canal, 24 mm is the length. 2/3 part is cartilaginous, 1/3 part is bony part. Here there is a fissure which is present at birth which closes with time called as fissure of Santorini. This can also come in your exam. Then ossicles are there which are part of middle ear. Then this auditory nerve, this semicircular canal, cochlea, they are part of the inner ear. So this is inner ear, middle ear and the external ear you have to study. Now bat ear is anti-helix is absent. As I told you, anti-helix is a part of pinna which is absent. Now for that plastic reconstruction is done at the age of 6 years, my dear friend. Then tympanic membrane develop from what? Tympanic membrane develop from all three layers, ecto, endo and meso. You can very well see the uppermost part is called as pars flaccida, lower one is called as pars tensa, and here you will see the malleus. Handle of malleus. This is lateral process of malleus, and handle of malleus then is going to be promontory. This is called as umbo, which is having a projection like this light. This is called as a cone of light. This is going to be anterior malleolar fold, and this is going to be the posterior malleolar fold. Posterior malleolar fold. Anterior malleolar fold. जिस साइड का कोन ऑफ लाइट होता है दैट इज गोना बी टेल यू अबाउट द डायरेक्शन ऑफ द ईयर. द एंटीरियर कोन है और पोस्टीरियर कोन है. दिस इज ऑल अबाउट द ओरिएंटेशन पार्ट. एंड पार्स फ्लैसिडा is having a layer called as your Sharpes membrane. Now coming on to the cuff reflex on stimulation of EAC. जब हम कान के अंदर कुछ खुजाते हैं तो कफ क्यों आती है? Because of the auricular branch of the vagus nerve, which is also called as Arnold's nerve, auricular branch of vagus nerve, which is called as Arnold's nerve. Now coming to the pinna hematoma causes trauma. You have to aspirate. If you not aspirate, there will be a necrosis, and because of necrosis, there will be malformation of the pinna. What if the wax is blocking the EAC? The treatment is syringing. How to do the syringing? Posterior superior direction. Don't use cold water, otherwise there will be a vertigo. You will use a lukewarm water or the normal water, I can say. Disease of external auditory canal, total 5 diseases we have to study. One is diffuse otitis externa, localized, malignant, and otomycosis. Diffuse otitis externa, it is an infection of a complete skin. Localized hairs are present, so frunculosis is there caused by Staphylococcus aureus. Treatment is ectamamol, glycerin. Packering. Malignant is important right here. You have to focus on malignant. Malignant is seen in the old and the diabetic patient. Earache plus granulation is there, and this is an infection of the bony canal of the external auditory canal. Treatment is third generation cephalosporin. Otomycosis, fungal infection of EAC. Most common fungus is aspergillus, wet newspaper type of appearance. This is also your exam question. Exostosis is nothing but your surfer's ear is there. There is a hyperplasia of the bony EAC, most commonly seen in the water sports persons. These are the 5 what you have to remember: localized otitis, malignant, and the otomycosis, important for the exam. Eustachian tube we have studied. This is a eustachian tube connecting your middle ear to the nasopharynx for the ventilation is there. The secretions we are getting middle ear cup out from the nasopharynx. If it is not getting out from the nasopharynx, it is going to be stuck on the tympanic membrane. If it is getting stuck on the tympanic membrane, the condition is called as what's your glue ear, or this is also called as otitis media with effusion. So remember OME. So remember what you will treat, how you will treat with the help of Gourmet myringotomy plus Gourmet incision. Will you remove Gourmet after 2 to 6 weeks? No, it will automatically come outside. Then coming to the middle ear ka nerve supply, middle ear sensory supply of the middle ear is done by tympanic branch of 9th nerve, which is also called as Jacobson nerve, which is also called as what, sir? Jacobson nerve, which is responsible for the referred otalgia from throat to the ear, sir. Now coming to the traumatic perforation, if you see the margins are very irregular, treatment is wait and watch. If not getting resolved, you have to go for the T plus T. Only repairing of the tympanic membrane is called as type 1 T plus T. In other word, we call that as myringoplasty. We call that as what, sir? Myringoplasty. Now coming on to the middle ear cleft ka infection. Middle ear cleft ka infection. This is ASO. Acute suppurative otitis media, infection of middle ear mucosa. Most common organs Streptococcus pneumoniae. Ear A cartwheel sign, very important. Red bulging tympanic membrane you are going to see. Treatment is myringotomy. If treatment not taken, it will lead to safe type of CSOM. Safe type of CSOM is also called as mucosal CSOM. Safe type of mucosal is also called the mucosal CSOM. Safe के अंदर there is a permanent perforation in the pars tensa. Discharge is not foul smelling, not blood stain, and there is gonna be conductive hearing loss if there is a ossicular erosion. Treatment, if only tympanic membrane is gone, you have to do the myringoplasty, repair tympanic membrane, and if ossicles are also gone, we go for the T-plasty. T-plasty is of different type: type 1, type 2, type 3, type 4. Not necessarily we do the type 3. If it depends on how many bones they are eroded, but most probably we do the type 3 T-plasty where malleus and incus both are gone. Now acute mastoiditis, infection of mastoid ear cell, pain behind the pinna is there. Ironing of the mastoid you are going to see. Reservoir sign and lighthouse sign. Reservoir sign is when the discharge is refilled on removing the previous one, that is the reservoir sign. If discharge continues to flow, that is called as lighthouse sign. X-ray mastoid, we are having Schuller's and Townes. Townes is not much useful, but Schuller's view is very useful to visualize the mastoid cavity set. Then coming to the short separation, which is also called as cortical mastectomy. Cortical mastectomy, you have to find the antrum. For finding the antrum, we are having two landmarks, a Mac-Evans and suprameatal triangle. Mac-Evans and suprameatal triangle. Now, sir, abscess related to the mastoiditis, Bizold and Citylis. Bizold is absent as sternocleidomastoid. Citily is digesting muscle. Zygomatic, you will see just above the pinna. Postauricular abscess. Bizold is sternocleidomastoid, and Citily is gonna be your digesting muscle. Then coming to the petrositis, which is also called as Grady-Nigo syndrome. The mnemonic to remember this is GERD. E stands for earache, R stands for retroorbital pain, and D stands for diplopia. This mnemonic you have to remember for your exam. Then coming to the unsafe CSOM. Safe to padli, unsafe. Unsafe is associated with cholesteatoma. Cholesteatoma is a mass of skin which is eroding the bone, which can also go to the brain. Most commonly where it is found in the Prozac space, sir. So there is an attic perforation you are going to see. Attic is involved most commonly. There is going to be a small amount of discharge coming outside. In that we do the modified radical mastectomy. We do, sir. Now, sigmoid sinus or lateral sinus thrombosis is a complication of unsafe type of CSM only, sir. There will be a headache. There will be a spiky fever, which is a picnet fence fever. Kabhi chadta hai, kabhi utarta hai. Pitting edema will be there on the mastoid surface, which is also called as Grisinger sign. And on CT scan, which sign you are going to see is a delta sign. Treatment may modified radical mastectomy, plus you have to clear the thrombus. Now, middle ear is also done. Now we are going to the next part called as inner ear, sir. Next part called as what, sir? Inner ear, sir. Inner ear, number one thing is called as what, sir? Cochlea. Organ of Corti is for the hearing. We are having cochlea here. Then we are having what's a lateral semicircular canal. Lateral semicircular canal is having a structure called as crista. Crista is for the angular balance. This utricle and saccule is having macula. Macula is for the linear balance. If linear balance is gone, the disease called as BPPV, that is benign proximal positional vertigo. We'll be talking about that separately. Fluid कौन से होता है sir? Inner ear के अंदर two fluids are there, endo lymph and perilymph. Endo is rich in potassium and para is lymph in sodium. The question comes, endo lymph is secreted by. Then your answer will be what's sir? Stria vascularis. Then your answer is gonna be stria vascularis. Then cochlea, if we talk about. If it's a cut section of cochlea, you see, there are the two membranes and the three vestibuli, you see. Now, two membranes are, one is resinous, another is basilar membrane. So, basilar membrane is in between the scala media and scala tympani, and the resinous membrane is between scala vestibuli and scala media. Now, this basilar membrane, you see, there will be organ of Corti. In organ of Corti, there is going to be what sort of tectorial membrane. This is a main organ. From here, your signals will be going to the brain. Mechanical energy is converted into the electrical energy, and they will be going to the brain for the listening processor. Now remember something called as this we have discussed. Yes, utricans and saccule is having organ called as macula. Macula agar disturb hota hai, there's gonna be benign proximal positional vertigo. Vertigo for few seconds on changing the head position. Diagnosis is Dix-Hallpike maneuver, and treatment is Apley's maneuver. Treatment is what, sir? Your Apley's maneuver. Then coming to the semicircular canal. Function is angular balance. Organ of Corti, sensory end organ is crista. Test is caloric test. Then hearing losses of two types, conductive and sensory neural hearing loss. Mostly your air conduction is more than the bore conduction. That is very, very normal, sir. Very normal, sir. How to test this? The most common test used is tunic for. The Rennes and Weber. First of all, Rennes पहले किया जाता है, Weber तो always answer is Rennes. Rennes test will differentiate between conductive hearing loss versus sensory neural hearing loss. So Rennes test हम करेंगे, we will check air and bone conduction. In Rennes test what we will check? We check air and bone conduction. So air conduction अगर ज़्यादा होगा bone conduction से, तो there are the two interpretation. One is SNHL, another is normal ear. If Rennes is negative, that means bone conduction is more than air conduction. That means this Rennes test is negative, having conductive hearing loss. Then Weber test is exclusively for the conductive hearing loss. They will tell you which side conductive hearing loss is there. So Weber, if you're going to the poor ear, that is gonna be your Weber always goes to the poor ear. So if right side is affected, that will go to right side, that is your right side ka positive aega, left side or the left side. If nothing is there, it will be centralized only. It will be centralized only. So let's see, according to this, as we told, Renes test is mainly for the sensory neural hearing loss. The AC more than BC is sensory neural hearing loss, and normal also AC is more than BC. But if BC is more than AC, then it will be conductive hearing loss. Then Weber test, heard in the center. Yes, if poor ear, conductive hearing, poor in the sensible, better ear, that is sensory neural hearing loss. Pure tone audiometry. You will see BCAC both less than 25 is normal. BCAC gap is more than conductive hearing loss. If BCAC both are more than 25, that's gonna be your sensory neural hearing loss. Now, two special dips are there. One is at 2000 Hertz, another is at 4000 Hertz. At 2000 Hertz BC, there's gonna be Hertz notch. This is seen in otosclerosis. And 4000, that's gonna be your noise-induced hearing loss, which is called as acoustic dip, sir. Two special audiograms are there. One is presbycusis, old age related, Meniere's disease से related है. They both are having sensory neural hearing loss. One is high frequency, another is low frequency. They both are They both are B for B. The presbycusis is having bilateral sensory neural hearing loss, high frequency, and Meniere's is having unilateral low frequency sensory. Audiogram, if you see, sir, sloping audiogram is a feature of presbycusis, rising audiogram is a feature of Meniere's disease. Then Bera is there. Bera sick babies के लिए किया जाता है. Autoacoustic is a healthy baby. Bera is having 7 waves. Out of 7 waves, 5th wave is very, very important. 5th wave is very, very important, sir. Then coming to the autoacoustic emission done. Then temanometric or impedance audiometry. You can see the curves right here, sir. If distal big mountain is there, DBM, then it is gonna be your normal. If flat curve is there, that is glue ear. If proximal big mountain, that is eustachian tube dysfunction, you are going to see. If distal small mountain is there, distal small mountain, then it is going to be otosclerosis. If volcano mountain is there, that is your ossicular dislocation. Now coming to the max permissible noise, that is 85 decibel for 8 hours a day for 5 days in a week. Then Bell's palsy, lower motor neuron palsy, there is going to be flaccid paralysis, ipsilateral half of the face is paralyzed, plus you are not able to close the eye. For that you have exposure keratitis, drug of choice is oral steroid plus artificial tears to prevent the exposure keratitis. Ramsay Hunt is a painful condition. If you see the Bell's palsy and Ramsay Hunt is a painful, there is a painful vesicles present. Drug of choice is acyclovir. And then coming otosclerosis. Otosclerosis is fixation of a foot plate of stapes. Mostly seen in the young female with the bilateral conductive hearing loss. Patient hears better in the noisy area, causes paracosis vilsi. Called as paracosis vilsi. 90% tympanic membrane is normal. 10% you are gonna have a flamingo pink appearance called as short sign. If short sign is present, treatment is sodium fluoride. If short sign is not present, treatment is stepidotomy. Then coming to the acoustic neuroma or vestibular schwannoma, sir. Acoustic neuroma or vestibular schwannoma, neurofibromatosis type 2 disease, chromosome number 22, benign tumor of the 8th nerve. Earliest, you will see CP angle. It is going to the auditory meatus. And remember, this is forming a ice cone in comb appearance. Unilateral sensory neural hearing loss. Yes, tinnitus, imbalance, rollover phenomena. The understanding of word increases with intensity, you increase the sound. फिर एकदम से क्या होता है, डिक्रीज होने लग जाता है. आप तेज तेज बोल रहे, सुनाई दे रहा है, एक थ्रेशोल्ड के बाद इट विल गो लो. दैट इज कॉल्ड एज योर रोल ओवर फिनोमिना. Investigation of gadolinium enhanced MRI, surgery is a treatment. Then coming to the glomus jugulare, site of origin is on the floor, under the floor of the middle ear. Floor of the middle ear, there is a glomus cell lying around that jugular bulb, highly vascular tumor, and most commonly seen in the female. Rising sun sign and brown sign, CT scan paper, Phelps sign will be there. Treatment is surgery. Meniere's disease or endolymphatic hydro. You know there are two type of fluids are there, endolymph and perilymph. Endolymph is triavascularis. So अगर ये fluid secrete होते जाते हैं, they are not able to come outside, they are not able to evacuate, they will be collected inside the inner ear, and that's gonna be problem. That's gonna be the problem called as glaucoma of the ear. So triad of the Meniere's disease, as we already discussed, Meniere's disease is a low frequency sensory neural hearing loss, and this is gonna be unilateral condition. On audiometry we are having what's your rising audiogram. So hearing loss, tinnitus, vertigo, there is gonna be Tumarkin crisis. What is Tumarkin crisis? Patient falls down during episode turning without turning unconscious. First of all, in between these episode you can also have a recruitment phenomena. What do you mean by recruitment phenomena? You will hear loud sound more loud, loud sound more loud. तुलियोस phenomena, patient get vertigo on hearing loud sound. जैसे आप जोर से बोलते हो patient को चक्कर आ जाते हैं. Diploicosis, one sound you are hearing in two frequencies. Investigation is electrocochleography. Treatment is medical treatment. You will give the diuretic etc. to reduce this fluid. If not getting, then endo-lymphatic sac decompression surgery we have to do, and in that the landmark is Donaldson's line. If still not getting resolved, then you have to kill the ear with the help of gentamicin. The last topic of ENT which we are doing right now, in 45 minutes I have summarized full ENT in front of you, all important topics. Hearing aid, if less than 85 decibel loss is there, if more than 85 decibel loss is there and eighth nerve is normal, cochlear implant. More than 85 decibel is there, eighth nerve is not normal, then auditory brainstem implant. So this is a world record. 45 minutes complete ENT done, 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 done. Now I'll take a nice short break and then we'll meet each other for the surgery career. So two subjects are done. We started at 10 sharp. Now it says 12:15. We are done with the two subjects. Another 2 hours will take to complete the complete surgery, pediatric surgery, adult surgery, and the cancers. And we will say very nice goodbye. And rest of the day you can study all your subjects. Thank you so much for joining us. Spread some love. Okay, and I'll be coming back at now 12:30. 12:30 will be the timing. I'll be coming back. Bye bye. Welcome back to the third subject in the last lap of three subjects: surgery, ophthalmology, and ENT. We successfully completed the two subjects. Now it's gonna be the surgery subject. Surgery weightage in the exam is 35 marks. It's gonna be important for the next 2 hours. Stay tuned with me, and we are gonna complete full of the surgery, sir. Now let's talk about this. Number one is surgical trauma. So, surgical trauma, number one thing is disaster management. So disaster management, we are having two things. One is simple triage and another is emergency severity index. Emergency severity index is by doctor and that is done at hospitals. The simple triage is done by paramedical staff and it is done at the site of disaster. That means what? The doctors do not go at the site of disaster. They do not go. They will be present at the hospital, and who is carrying all the affected people from the disasters place? That is going to be your paramedical staff. Now there's going to be color coding, whether the people required a first aid, whether the person required surgery. For the people who need surgery, they'll be shifted to the hospital. People who need first aid, they'll be just given first aid and sent back home and call for the follow-up in the hospital. That's going to be your simple triage. Emergency severity index is again done by the hospital, where there's a red, green, and yellow, black. Those kind of color codings are done in the hospital. Now, at hospital, what is the primary and secondary assessment? The primary and secondary assessment, what we do in the hospital, number one, primary is airway, breathing, circulation, plus there is a scoring. This scoring we are going to talk briefly. The scoring is called as TRIS, that is trauma injury severity score. It is having your age, injury severity score, and revised trauma score. The scoring system is age, injury severity, and revised trauma score. My difference: injury severity score is anatomical scoring and revised trauma score is the physiological scoring. This revised trauma score is also called as Q-SOFA scoring. R stands for respiratory rate, T for trauma में GCS देखते हैं, S stands for systolic BP. So this is how you have to remember this, sir. Scoring system is your injury severity and your revised trauma. Revised trauma is also called as Q-SOFA score, sir. Q-SOFA scores. Then secondary assessment is all about the history taking and the examination. The primary is airway, breathing, circulation plus scoring, which scoring TRIS. TRIS is having age, injury severity, and revised trauma. Injury severity is anatomical score. Revised trauma is your physiological score. In this, we are having systolic BP, respiratory rate, and GCS, my dear friends. Now coming to the triage. The hospital triage where we do is the PDF you are going to find on the Bhanu Prakash channel and Chanting wala. Both the telegrams you are going to find the PDFs. Now red, yellow, green and black. Red color, you need surgery immediately. Yellow, surgery needed within 6 hours. Plus all the fractures are coming in this yellow category. The patient who can walk would be considered as a green category, and pulseless patient is gonna be, or dead patient is gonna be your black wala category. Now coming to the head trauma. Head trauma investigation of choice is NCCT, anterior cranial fossa and middle cranial fossa fracture. This is again an ENT topic we are covering in surgery. The anterior cranial fossa fracture, cribriform plate is gone, and middle cranial fossa fracture, your petrous part of the temporal bone is gone. So how they are gonna present? They are gonna present raccoon eyes or panda eyes. You can appreciate very well here. And middle cranial fossa fracture, you are going to see the Bettel sign. In the middle cranial fossa fracture, you are gonna see the CSF otoria. And in the anterior cranial fossa fracture, you are going to see the CSF rhinoria. Then EDH, SDH, very simple, sir. EDH, you will see the idli shape hematoma is there. Idli is best cooked by mama. So your causative will be your middle meningeal artery. Middle meningeal artery, and this is associated with lucid interval. The person will be sane, insane. That means person is awake and person will be unconscious. Unconscious, conscious, that is gonna be the lucid interval associated with the extradural hematoma. Plus, this is gonna be your sickle shape hematoma. This is gonna be what, sir? Your sickle shape hematoma. Sickle shape hematoma. Okay? Sickle shape hematoma. Very nice. Sickle shape hematoma, remember, this is sickle shape. Everyone has to cross the bridge. So bridging vein को injury होती है. इसको injury होती है sir. Bridging vein को injury होती है. That's what you need to remember. Primary management in the head trauma decrease intracranial pressure plus increase the cerebral perfusion. Medical management, yes, mannitol, IV fluids, blood platelets, fresh frozen plasma. Surgical management, you have to decrease the intracranial pressure. If it is not decreasing, then you have to go for the burr hole surgery. Burr hole surgery you are doing from the site is Tyrion. You are doing from the site called as what's a Tyrion. Then facial trauma, upper face we have studied in ENT, Lefort's classification 1, whereas there is a transverse fracture line, pyramidal fracture line and craniofacial disjunction. Lower face we are having most common mandibular fractures. Investigation of choice is gonna be what's your orthopentamogram. Image based question can come and can ask you which view is this. Treatment of a facial trauma is always gonna be open reduction with the internal fixation with plates and screw, because angle of mouth is very important. You just not leave it because there might can be a deviation and that will be a problem, cosmetic problem throughout your life, or might can your facial nerve get compromised and that will lead to the deviation of the mouth. So for that purpose, open reduction and internal fixation with the plates and screw is very important. Now coming on to the neck trauma. So head trauma is done, facial trauma is done. Now we'll move for the neck trauma. So there are two type of forces. One is blunt trauma force, another is penetrating trauma force. So blunt trauma, cervical spine ka injury, there will be a whiplash injury, immobilization with the help of cervical collar is very important. And if patient is immobilized, patient you have to intubate in case of a blunt trauma to the neck. Cervical spine is gone. Then which maneuver you will give? That is your jaw thrust maneuver. Jaw thrust maneuver. Then coming next one is penetrating trauma. Zone 1, Zone 2, Zone 3. Zone 1 is the most dangerous zone and Zone 2 is most common zone. What these zones are? Let me tell you sir right here. So sternal notch to cricoid cartilage. This is gonna be Zone 1. Cricoid cartilage to the angle of mandible is gonna be 2. Angle of mandible to the base of skull, that's gonna be 3. Most dangerous gonna be this. Most common is gonna be this. Now the shock index calculation is very important. This can come in your exam anytime and you have to know it. Shock index is pulse upon systolic BP. Shock index is what's it? Your pulse upon systolic BP. If the shock index is more than 1, that means the person is hemodynamically stable. That's very important. Pulse upon systolic BP. Pulse upon systolic BP. Now sir, if the patient is hemodynamically unstable, that means shock index is more than 1. Then surgical exploration is required, and if hemodynamically stable, then investigation plus non-operative procedures you have to do. Now fourth type of trauma after the neck is gonna be a chest trauma. Most common site is gonna be the left side, sir. Pneumo and pneumothorax. Let's see sir. Pneumothorax, you can see your trachea is midline, lung is collapsed and there is air in the cavity. Then coming to this one, your CP angles are blunt, the fluid is present there. This is called as hemothorax. For both of them, the treatment is a tube thoracostomy. In adult, 5th mid axillary. In children, it is 2nd mid clavicular. Tension pneumothorax. Mediastinal shift is there. Lung is completely blocked and air is entrapped inside the cavity. Black jet lung is there. This is kind of a surgical emergency. Treatment is needle thoracosynthesis. Needle thoracosynthesis. Site in adult is again 5th mid axillary line, and children it is 2nd mid clavicular line, sir. Then coming to the next one is sir, flail chest. More than 2 consecutive ribs are gone for more than 2 sides, sir. Treatment is analgesic, oxygen, positive pressure ventilation. That is important. Abdominal trauma. The most common injury in the blunt trauma would be your spleen, and in penetrating, that is gonna be your liver, because liver is covering most of the space, sir. Investigation number 1 is gonna be your fast. If fast you are doing, you are not visualizing one cavity, and that is your pleural cavity. If pleural cavity you have to visualize, you have to do E fast. E fast. You have to do what, sir? E fast. Investigation of choice is gonna be your CECT abdomen. And the zones, if you see in the abdominal trauma, the most common zone injured, that is gonna be zone 1 because of the maximum blood supply. So the hemodynamically stable, you are going to do observation. Hemodynamically unstable, you have to do the laparotomy. That is exploratory laparotomy is your best answer, and this is going to be your previous year question. Then it's going to be hypovolemic shock. Hypovolemic shock is going to be your most common cause of death in the trauma. The earliest sign going to be tachycardia. The first earliest is tachycardia. Then early sign is gonna be cutaneous vasoconstriction. Late is gonna be vasodilation. Cardia, vasoconstriction. Then late is gonna be vasodilation. Airway, breathing, circulation, IV fluid, blood platelet, fresh froze plasma, plus direct control of bleeder. Bleeder ढूंढना है, and you have to block it, sir. Then coming on to the next topic called as what, sir? Your hemorrhage. So blood loss categories are there: 0 to 15, 15 to 30%. 30 to 40% and more than 40%. Okay, 0 to 750, 750 to 1500, 1500 to 3000, more than 3000 ml. Like this also we can read, sir. This can come in the exam. So blood loss category 1 is up to 15%, 15 to 30% would be 2, 30 to 40% gonna be 3, and more than 40% gonna be 4. Then coming to the thermal burns. Most common day to day is scald or hot liquids. Most common in the hospital is gonna be the flame burn, and most common source of infection is gonna be pseudomonas. This is your previous year question. Other than that, total body surface area calculation is very, very important. Most common in adult, we are using a Wallace rule of 9, and in children we are using Lund and Browder's chart. Depth of burn. If you see this diagram, first degree, second degree, third degree, and fourth degree, we'll see this. First degree only epidermis plus dermis, that's gonna be your second degree. Epidermis, dermis, subcutaneous gonna be third degree. Then along with the muscle gonna be fourth degree. The blister formation is common in second degree burn. First and second degree are painful. Third and fourth degree are painless burn. Third and fourth are the painless. Management in the burn patient. First is airway, breathing, circulation. If the airway is burned, then you have to insert the endotracheal tube. If fluid of choice you have to choose, that's gonna be your Ringer lactate solution, and you have to give with the help of ATLS formula. What is the ATLS formula? That is different for the adult, for the children, and for the electric shock patient. Sir, your adult are 2 people, male and female. That is gonna be your 2 into percentage of burn into body weight. Okay. चिल्ड्रन आ जाते हैं तो 3 हो जाते हैं, दैट्स गोना बी 3 into percentage of burn. जब कोई इलेक्ट्रिकल शॉक लगता है, मर जाता है, 4 लोग कंधे से उठाते हैं, दैट्स गोना बी 4 into percentage of burn into body weight. Now you are getting the x value. X by 2 are you are to going to give in the first 8 hours, and another x by 2 are you are to going to give in the 16 hours, sir. Then Parkland formula is no more used these days, sir. Then skin grafting, sir. Auto, iso, allo, xeno. Very important. Isograft is of a same person. Iso is identical twins. Allograft is same species. Xeno is different species. We all know. Instrument is Humphreys and Wolfe's Knight. Image-based question can come. 2 type of grafts are there. ENT mein also I was telling you that partial thickness and full thickness graft is there. Partial thickness where you are taking epidermis and subdermis. Full thickness you are taking epidermis and complete dermis. Partial thickness most common donor site is thigh, and the full thickness most common donor post auricular area, your clavicular area. These are the area from where you can take the full thickness grafts. The most common cause of immediate death in the burn patient is gonna be hypoxia. Early death is gonna be hypovolemia. Late cause is because of a sepsis caused by the pseudomonas. Chemical burn, acid and alkali. C will lead to coagulative necrosis, and alkali will lead to liquefactive necrosis, which is also called as colliquative necrosis. Treatment of a chemical burn is gonna be your irrigation with the running water. Now coming to the next one, sir. Cold burns, cold burn, frostbite in trench foot is gonna be there. And treatment to this is gonna be your rewarming with the water, analgesia plus surgery plus vasodilators, calcium channel blockers, etc. are also helpful. Then let's classify the surgical wounds. Class 1 says it's a clean wound. Class 2 says it's minimal contamination. Class 3 says significant contamination. And class 4 is gross infection, gross contamination. Minimal, significant, gross, and no contamination. This is how your 4 categories of surgical wounds are divided. Now coming to the favorite question of examiner, that's gonna be differentiating between the hypertrophic scar and keloid. Hypertrophic scar margins are regular, keloid is extended. Color is gonna be darker in the keloid as compared to the hypertrophic scar. Then where it is present, the keloids are mostly present in the ear, pinna, shoulder and sternum. Hypertrophic scar can be present anywhere. If we have to treat the keloid intrakeloidal injection, we have to inject. Which injection we are talking about here is a triamcinolone. Hypertrophic scar is gonna be there. We are going to apply the local creams. Now gonna be the next chapter. That's gonna be the vascular surgery. The vascular surgery, number 1, we are dividing this into 2: gradual arterial obstruction and sudden arterial obstruction. So 2 things we have to study here, sir. Gradual and the sudden arterial obstruction. If we see the gradual, the most common cause is atherosclerosis, next is Buerger's disease. So this atherosclerosis is having a very special feature called as intermittent claudication. What do you mean by intermittent claudication? The pain on calf muscle on walking and relieved on further walking. Or if it is grade 3, the pain subsides, the pain is still there and patient sits there. That's the third thing. Then Boyd's grading, which I was talking about. If a patient is having pain, continues to walk and it gets relief, is grade 1. Patient is having pain, on further walking it is relief, is grade 1. Patient walks with pain is grade 2. Patient sits, that is gonna be grade 3. Then coming to the complication of atherosclerosis, in the distal part, you are going to see the gangrene. Clinical examination, you have to feel the pulse. So 2 pulses are important pulse. One is popliteal, another is dorsalis pedis. Popliteal is the most difficult pulse to feel and dorsalis pedis is felt at the first metatarsal space. Why this popliteal is gonna be very difficult? That's gonna be difficult because of the deeper course of the pulse. Now, aim of management in this atherosclerosis, we have to again give the blood supply to relieve the symptoms. So we do a lifestyle modification first, weight reduction, smoking, etc. You have to quit. Medical management is vasodilator and antiplatelet drugs we can give. And the catheter which we are using in the vascular surgery is your again MCQ, that is gonna be your Fogarty catheter. And treatment ke andar if not working fine, then you have to go for the bypass grafting, and this bypass best graft use is a great saphenous vein. Also we can use for lima rima. If arterial graft we have to use, then lima rima. Venous graft we have to use, then it is a great saphenous vein we have to use, sir. Then coming to the Buerger's disease, this is gradual, but it takes some time to develop. Gradual Buerger's disease or thromboangiitis obliterans. The most common cause over here is smoking. It can involve arteries, vein, nerves, but never your lymphatics. There's gonna be rest pain. No cigarette, no medical management, calcium channel blocker, lumbar sympathectomy to relieve the pain. What will happen in the lumbar sympathectomy? See, if we do the lumbar sympathectomy, the blood will go into the distal area. So this is gonna be your hand. Black hand will be there. Young male smoker, black color because of the gangrene. On angiography, you are going to see the corkscrew appearance. Corkscrew appearance on angiography. This is gonna be your Buerger's disease. Treatment is no cigarette, lifestyle modification. That's gonna be the mainstay, sir. Sir, if you need PDF, my telegram is there, chanting wala. Dr. Bhanu Prakash sir's channel is there. Dr. Bhanu's channel is there. 2 of us are providing you PDF today. Okay. Now coming to the third one is Raynaud's disease. Raynaud's disease is having Raynaud's phenomena. So why this disease is happening? Because of the cold exposure. ठंडे पानी से बर्तन साफ करने से the most commonly affected person would be female. There will be a pulse which is normal. Pulse is gonna be normal. So there is gonna be the Raynaud's phenomena. First of all, it's gonna be white color skin, then it's gonna be blue color, then it's gonna be red color. Then there is a primary and secondary Raynaud's. Primary Raynaud's is not associated with any systemic disease, and secondary Raynaud's, yes, it is associated with systemic diseases like SLEs, rheumatoid arthritis, etc. Now treatment for this Raynaud's phenomena is lifestyle modification. बर्तन ठंडे पानी से नहीं मांजने हैं. You can use the lukewarm water. Plus, if doesn't subside, then we have to give the calcium channel blockers and the nitrates, which are the vasodilator drugs. Now, gradual one is done, sir. Now we have to switch on to sudden arterial obstruction. What is the reason behind the sudden arterial obstruction? So if there is a sudden arterial obstruction, number one thing you have to think is embolism. So if there's embolism, there's gonna be pain, pallor, pulseless paresthesia, and pykilothermia. These are 5 P's. Treatment for the emboli is the first a low molecular weight heparin to prevent the extension, plus thrombolysis by the TPA, streptokinase, urokinase agents, etc. Coming on to the next one is, sir, varicose vein. Now, the blood flow of the vein is from superficial vein to the deep vein. If your valves are incompetent, then what will happen? Your blood will accumulate in the superior vessels and they will look prominent. So remember, what are the risk factor? Prolonged standing. Surgeons, etc., policemen who are in traffic, they are the risk factor. Pregnancy, pelvic tumor, and deep vein thrombosis. Okay. Now, vascular incompetency we have discussed. Complication is gonna be venous ulcer that will lead to Marjolin's ulcer that will lead to squamous cell carcinoma. So your varicose vein can lead to squamous cell carcinoma. C1, C2, C3, C4, C5, and C6. If spider veins you see, that is C1. Varicose vein is itself a C2. If edema is there, C3. Skin changes, you will see C4. Venous ulcer, which is Marjolin's ulcer, which can lead to squamous cell carcinoma, is gonna be C5 and C6. How to check it? How to check it? The checking is done with the help of Brody's Trendelenburg test, which is for the valvular incompetence, and Fagan's test is for the perforator incompetence. So perforators छोटे होते हैं, valve बड़े होते हैं. Investigation of choice is duplex imaging, where you will see the sphenofemoral valve incompetency, and that is shown with the help of Mickey Mouse sign. That's gonna be seen with the help of Mickey Mouse sign. Mickey Mouse sign. Early management and late management. Early is gonna be lifestyle modification. Avoid prolonged standing, limb elevation, elastic compressions you have to wear. Then late is gonna be laser ablation and sclerotherapy. Also, you can use a surgery called as Trendelenburg operation for the valvular incompetency and subfacial endoscopic perforator surgery for the perforator incompetency. Then gonna be next one, that is deep vein thrombosis. Deep vein thrombosis is also a risk factor for the varicose vein. So most common site is gonna be calf vein, and prolonged immobilization is a theory. You have to remember the virtuous triad, which is a previous year question. There's gonna be endothelial injury, because of which there will be a stasis and because of which there will be hypercoagulability. Endothelial injury से सारा फसाद शुरू हुआ, stasis हुई, hypercoagulability होगी. Homan and Moses sign. What is this? The resistance to the dorsiflexion. Moment there is a deep vein thrombosis, the person is trying to dorsiflex it, there's gonna be intense pain. Plus, if you're gonna squeeze the calf muscle, there's gonna be excess pain. So this is Homan's and Moses sign. Investigation of choice is duplex imaging. Test ke naam pe we are going to do the Perthes test, and treatment can the low molecular weight heparin to stop the extension. Plus, we can give the oral warfarin also. If recurrent DVT is there, we'll try to put a mesh, that is IVC filter we are putting. Moving on to the next part of surgery, that is your endocrine surgery, sir. Number one thing we have to discuss is goiter. The enlargement of thyroid gland, most common cause iodine deficiency. Diffuse and nodular. Diffuse goiter would be reversible, and nodular is not reversible. Sign and symptom, if goiter is there, pressure symptoms are there. Okay, and other thing is dyspnea, dysphagia. These are the pressure symptoms. Plus Pemberton sign is positive, and these pressure symptoms are only seen if retrosternal extent of goiter is there. The complication is secondary thyrotoxicosis, follicular thyroid cancer. These are some complication which can happen. And now the investigation is ultrasound guided FNAC we do. Then to check the extent, CCT also neck we do, sir. Then coming to the treatment part, if one lobe is involved, hemithyroidectomy. If two lower lobes are involved, subtotal thyroidectomy. If we are removing all of the thyroid, excluding a small lobe near total, and then coming to the total, that is your total thyroidectomy. Total thyroidectomy. Next comes to the breast, and before doing this, papillary and follicular you have to read. The papillary ka most common cause is radiation to the neck less than 5 years. Then follicular is long standing endemic goiters that can lead to follicular. In follicular, you are gonna see Hurthal cell tumor. Hurthal cell tumor. Hurthal cells you are gonna see. And in pathology, in the papillary, orphan eye or samoma bodies, you are gonna see tumor marker is serum thyroglobulin. Treatment is total thyroidectomy with the central lymph node dissection. Coming on to the next one, breast. Breast is nothing but your modified sweat glands. That is nothing but your modified sweat gland. The most common cause of breast cancer, most common site of breast cancer with the maximum tissue gonna be your upper outer quadrant. Then coming to the one disease called as mastitis. Baby के mouth से Staphylococcus aureus is gonna touch the mother's का breast and that's gonna cause inflammation. Sir, remember, treatment is antibiotic breast support. If abscess is there, incision, drainage followed by antibiotic. Now you have to summarize this table in your head. What are the different type of discharge which is coming from the nipple? The most common discharge is milk. Most pathological discharge is serous. Greenish discharge is duct ectasia and bloody discharge is duct papilloma. Now duct ectasia, there is a drying and dehydration of the breast. Because of that, there is a blockage of the lactiferous ducts, and because of that there will be greenish color discharge. Treatment is plenty of fluid plus breast support. If not getting relieved, if one duct is involved, microdecotomy. If multiple ducts are involved, head field operations we have to do. Duct papilloma, the most common cause of bloody discharge from the nipple. If one lobe is involved, one duct is involved, microdecotomy. Multiple ducts are involved, then head field operation. Now most common benign breast tumor is fibroadenoma. Less than 30 fibroadenoma, more than 30 invasive breast carcinoma. Now fibroadenoma, there is a benign breast tumor, hyperplasia of the intralobular stroma. Breast lump is there, freely mobile. Also you'll see the popcorn calcification. How to investigate? Clinical, radiological and pathological. If a woman age is more than 35 years, we go for the mammography. Less than that, we go for the ultrasound. Now coming out of the size, less than conservative, if size is increasing, then we have to do the excision. Cystosarcoma phyloides is known as phyloides tumor. Vigorous mass you can see, freely mobile onto the chest. Treatment is wide local incision. Then coming to the next one is breast cancer. Overall, most common cancer in the world is the breast cancer, but the cancer causing death is gonna be your lung cancer. Gene involved is both BRCA1 and BRCA2. If both are these involved, there will be a risk of ovarian cancer along with the breast cancer would be there, sir. Then coming to the clinical feature is BPT, breast lump, dimpling of skin and pudgy orange. This is gonna be your question of the exam, pudgy orange. It is due to blockage of subdermal lymphatics. It's gonna be blockage of subdermal lymphatics. This is gonna be your question of the exam, sir. Then coming to the spread by blood and lymphatics. If blood spread is there, lumbar vertebra. If lymphatic, then it is by the axillary lymph nodes. Then coming to the treatment part. Breast conservative surgery, we do removing the margin 1 mm only. Radical mastectomy, we try to remove the lymph nodes also. Chemotherapy में drugs used are atria and cyclophosphamide. Menopausal therapy, hormonal therapy. For the ER/PR positive one, we try to give the hormonal therapy, and that's different from premenopausal and postmenopausal. Premenopausal, this is gonna be tamoxifen. Postmenopausal, this is gonna be anastazole, aromatase inhibitor. The target therapy is only given if the receptor positive HER2/neu is there, and that is trastuzumab. And if sentinel lymph node is positive, you have to remove all the lymph node. Now IHC distribution, ER/PR, HER2/neu and Ki67. Luminal A, B, HER2/neu and basal. These are the four you have to remember for the exam. Luminal A is ER/PR positive, HER2/neu negative. Luminal B is triple positive. HER2/neu is only HER2/neu positive, and basal is triple negative. Out of this, luminal A is having the best prognosis. If we talk about the Ki67, only luminal A is having Ki67 low, rest 3 are having high, sir. Now coming on to the next topic called as what's your pediatric surgery. Next topic called as what's your pediatric surgery. In pediatric surgery, sir, the number one topic we are going to talk now is called as cleft lip and cleft palate. Risk factor, genetic, drug intake, phenytoin, diazepam can also lead to this. The breathing difficulty, speech difficulty, yes, gonna be there. Treatment can the plastic reconstruction we are going to do in the cleft lip and cleft palate, and genetic cause is there, then it is gonna be a Patau syndrome. Then thyroglossal cyst. Accumulation of secretion in the thyroglossal tract, swelling moves with deglutition and protrusion of tongue. If only with deglutition is there, then it is gonna be your thyroid swelling. And if it is moved with the protrusion of the tongue, that is going to be the thyroglossal cyst. Complication is thyroglossal fistula, papillary thyroid cancer, जिसमें orphan eye nuclei we were seeing, samuma bodies we were seeing. Treatment के नाम पे cyst tongue operation, where excision of a tract is there plus excision of cyst is there. Cystic hygroma. The lymphatic fluid inside the lymphatic sac is going to be there. Clinical test, the trans elimination positive. Treatment is sclerotherapy and complete excision will do. Plus we'll put a torch here, it will glow like a bulb, sir. It will glow like a bulb, sir. Esophageal atresia. What do you mean by atresia? Absent of some part of esophagus. That is gonna be atresia. The most common type is gonna be type C. This is gonna be trachea, this is gonna be esophagus, upper end is blind. If we put a nasogastric tube, this is going to be coiling here. Plus continuous dribbling of saliva you are going to see. So this is a type C. Investigation of choice is coiling of NG tube. You'll see investigation of choice is CT scan. Most common presentation is continuous pouring of saliva from the mouth, and treatment is esophagostomy. You have to anasmose the two ends of the esophagus. Dysphagia lusoria. There is a compression of the esophagus by the aberrant right subclavian artery. राइट सबक्लेवियन आर्टरी का साइज बड़ा हुआ, साइज बड़ा होने के साथ उसने अपने इसोफेगस को कंप्रेस कर दिया. दिस इज गोना बी डिस्फेजिया लुसोरिया. Abdominal atresia, single bubble, double bubble, triple bubble, multiple bubble. Single bubble you are going to see with the pyloric atresia, this one. Double bubble is duodenal atresia and annular pancreas. Triple bubble is gonna be your jejunal atresia, and multiple bubble there's gonna be perforation. There's gonna be what's a perforation. Treatment में duodenoscopy, however the things are absent, you have to anastomose it as two parts. Then CHPS stands for congenital hypertrophic pyloric stenosis. This hypertrophic of a pyloric muscle is there. Presenting age is third week, olive shaped epigastric lump is there. Projectile non-bilious vomiting is there because blockage is happening right on the pylorus itself. And metabolic alkalosis will be there because the patient will be vomiting outside, sir. Plus there will be a hypokalemia. USG में you will see thick pyloric mass 3 to 4 mm. Emergency में you have to plus first rehydrate. Then you have to put the balloon, pneumatic balloon dilatation you can do. If not getting relief, then treatment of choice is Ramstead pyloseromyotomy. And here you will see the mushroom sign. The barium meal के अंदर you are going to see the mushroom sign, sir. Then coming to biliary atresia, like we have studied the esophageal atresia and biliary atresia, the absence of biliary channel. So type 1, type 2, type 3. There is going to be common bile duct. There is going to be hepatic duct, right hepatic duct, left hepatic duct. Sir, if your common bile duct is absent, that is type 1. Treatment is hepatico-jejunostomy. Hepatic duct को जोड़ दिया jejunum के साथ, hepatico-jejunostomy. If common hepatic duct, right and left hepatic duct is absent, that is type 2, type 3. Treatment is Kasai operation. Clinical feature of biliary atresia, there is gonna be jaundice, LFT करना है. Investigation to see the biliary channels is always gonna be the HIDA scan. It's always gonna be the HIDA scan. Now, choledochal cyst, cystic dilatation of the biliary channel. Todanis classification 5. Type 3 तक this is gonna be in the bile duct, and type 4 and 5 this is gonna be your hepatic ducts. Treatment दोनों बेस पे करना है. दोनों बेस पे किस में करना है? OPD and emergency. OPD में the patient will be coming with the painless jaundice plus mass in the hypochondric region, right one. Investigation of choice is ERCP. Cystic excision with hepatococcygeostomy, same will do. Emergency में charcot stride, pain, fever, jaundice. If septicemia and mental confusion is also there, then it is gonna be Raynaud's pentod. Investigation of choice is ERCP, antibiotic and fluids we have to give. Then we have to do the ERCP की मदद से endobiliary stenting. Emergency में anti IV fluid, antibiotic के साथ में stenting etc. We have to do charcot stride, pentad, you have to take care. Natodanis classification, if you see right here, so type 1, type 2, type 3, type 4A, 5. Fusiform, most common. Type 1 is fusiform, most common. This is going to be cystic dilatation in the common bile duct. Then, sir, there is a diverticula in the common bile duct. Then, if the diverticula is there in the duodenum, that's gonna be type 3. Type 4 is multiple intra and extra hepatic dilatations are there. Type 5 is extra hepatic only. Gonna be very simple. Big dilatation type 1, that is in the common bile duct. Small dilatation or diverticula type 2. The duodenum के अंदर type 3. 4A is multiple inside outside and 4B is only outside. So this is what you are going to learn in the Todanis classification. Then it's going to be 9th one in the pediatric, that is going to be your intussusception. Intussusception is nothing but telescoping of the intestine. The most common site is going to be your ileocolic junction. Sausage shaped lump is there. Red recurrent jelly stool is there. US abdomen, ultrasound abdomen, donut sign, claw sign, coil spring appearance. Target sign you are going to see, sir. These are the important signs. In radiology also we have studied. Treatment is hydrostatic reduction by the air enema. If not getting, then end-to-end anastomosis. Which vaccine, virus, which vaccine is associated with intussusception? Your answer is rotavirus. Rotavirus is the most common cause of diarrhea in the newborn बच्चों. Polycystic kidney disease, autosomal dominant, recessive दोनों होते हैं. Multiple cyst you will see on the kidney. Initial treatment is de-roofing of the cyst and permanent management is a renal transplant. ठीक है, renal transplant. And on intravenous pyelogram, you are going to see spider leg appearance. This is gonna be spider leg appearance. Typical one-liner questions you have to remember for exam. Sir, horseshoe kidney. There is a fusion of two lobes of the kidney. Site most common is L4, L3. TCT is investigation. Flower vase will be seen on the intravenous pyelogram. Treatment is division of two kidneys here. Meckel's diverticulum. All the layers of the intestines are out. There is a rule of 2. Rule of 2 says 2 centimeter wide, 2 inches long, 2 feet from the ileocecal junction, present around 2 years of age. These are the rule of 2 you have to remember right here. Again, I want to repeat. 2 centimeter wide, 2 inch long, 2 feet away from ileocecal junction, presenting around 2 years of age. If your Meckel's diverticulum is found in hernial sac, this is called as Litter's hernia. Complication can be bleeding, ulcer, intussusception. Meckel technetium scan is gonna be better answer than barium meal. Follow through. If asymptomatic, no treatment is Meckel's diverticulum. If symptomatic, resection and anastomosis will be the treatment. Next gonna be the Hitchcock disease. This is gonna be the megacolon. Absence of ganglion cell in the nerve plexus. These are the pacemaker of the mass movement, son. If they are absent, there is gonna be the megacolon. You have to do the suction biopsy to check whether there are cells or ganglionic cells are there or not there. If they are not there, definitely this is gonna be the Hitchcock disease. And treatment के नाम पे you are going to do Duhamel's and Swenson's operation. Next is gonna be your ureterocele. There is a ballooning of the ureteric end inside the bladder. This is gonna be the adder head or cobra head appearance. Treatment is you have to do the incision, longitudinal incision to cut it. Now coming to the posterior urethral valve. There is a valve present around the urethra. An investigation of choice is micturating urethrogram. The valve will be constricting it. There will be a keyhole sign. keyhole sign you're going to see. Then hypospadiasis, congenital anomaly of a male urethra where the abnormal opening will be there. Sir, the most common type and least dangerous type is gonna be granular. Sir, least common type and most dangerous type is gonna be the perianal. Is gonna be perianal. Treatment में urethroplasty 6 to 18 weeks we do. Only contraindication is circumcision. If hypospadias is there, we don't have to do the circumcision. Then coming to the next one, the undistended testis, sir. There's a congenital anomaly where the male testis is gonna stuck. What is a normal path? The normal path first is a deep inguinal ring, inguinal canal, superficial inguinal ring, then it's gonna come inside the scrotum. So if they're arrested in this normal path, this is gonna called as undistended testis, and if this is going on to the other side, this is called as ectopic testis. How to investigate? If palpable, do ultrasound. If not palpable, do the laparoscopic diagnostic laparoscopy. Treatment is orchidopexy 6 to 18 months. And most common cause of testicular malignancy is your most common cause of testicular malignancy in the undistended testis, that's gonna be your seminoma. That's gonna be what, sir? Your seminoma. This we have completed the pediatric surgery part also, sir. Now we are moving on to the next part, that's gonna be what, sir? Your adult surgery. That's gonna be what, sir? Your adult surgery. Okay, so adult surgery, PDF chanting wala Dr. Bhanu sir channel, chanting wala Bhanu sir channel. Okay, so let's take a short break and then meet back. Now it's 1:11. Let's meet at 1:20. 10 minutes ka short break, water break is there. I'm kind of dehydrated, need some water to freshen up back, and let's then complete the class. Welcome back, ladies and gentlemen. And we are back. I took break because it's too exhaustive here. AC is not working, plus a lot of lights focusing on me. That's why I need some water. Sorry for that. So let's come back to the adult surgery part. After completing the adult surgery part, we'll be switching on to the cancers, and then we are done with the surgery ka part. Okay. So surgery number 1, we have to talk in the adult surgery. Okay. Thank you so much, Sanrash. Eclasia cardia. Eclasia cardia is nothing but a failure of relaxation of lower esophageal sphincter. Sir, there will be a dysphagia. Initially, that is for liquids, then it will go to the solids. Liquids are lighter, and once solids will come, they will open the lower esophageal sphincter. And on the barium swallow, you will see there is a bird beak appearance. There is what, sir? Bird beak appearance. Bird beak appearance. And sir, standard investigation is esophageal manometry. This is to check the pressure in the esophagus. Normally, this is gonna be 25 to 100. No, sorry, in the this eclasia cardia, it is going to be 25 to 100 mmHg. 25 to 100 mm. Less than 25 mmHg is gonna be normal. Then treatment is drugs like calcium channel blockers and nitrate. And the surgery, you have to remember, bird beak appearance, bird sings poem. So poem is per oral endoscopic myotomy. Very simple answer to the very simple question. Next is very famous topic of examiner, that is going to be your GERD, gastroesophageal reflux disease. The normal lower esophageal sphincter relax 3 to 4 times in 24 hours. Risk factor is gonna be smoking, alcohol, tea, coffee, etc. Clinical feature is heartburn, epigastric pain and regurgitation. Investigation, you have to do 24 hours of pH monitoring. And there is a score called as Johnson's D Master score, which is a gold standard investigation for this. Johnson's D Master score says pH less than 4 times for more than 4 times in 24 hours. pH 4 se kam, more than 4 times in 24 hours. That's gonna be your Johnson's D Master score, which is a gold standard investigation. G for G, that is GERD. GERD initial treatment is lifestyle modification, then coming to the PPI. And if still not getting resolved, we will go for the surgical management. That's gonna be floppy Nissen fundoplication. Floppy Nissen fundoplication. PPIs ke sath mein also we can give the drugs like sucralfate, etc. Okay. Now complication of GERD is gonna be Barrett's and sliding hiatus hernia. What is this Barrett's esophagus? When the intestinal columnar cell is replacing the squamous of the lower esophagus, then hallmark is gonna be goblet cell. Treatment is PPI, resection of the lower esophagus and gastric pull-up operation you are going to do. Simple and sorted, sir. Now, second complication of GERD would be your hiatus hernia. These are of 2 types. One is sliding hiatus hernia, another is paraesophageal rolling or giant hiatus hernia. My dear friends, if we talk about the GE junctions in the sliding, that's present in the thorax, and in the paraesophageal rolling or joint, which is the same thing, only this is present in the thorax. Plus reflexes present in sliding, it is absent in paraesophageal. Rest everything is same, whether it's chest pain, dyspnea, CECT, fundoplication, rest everything is same. Bohr-Harvey syndrome. Bohr-Harvey syndrome is spontaneous esophageal perforation after eating, binge eating after binge drinking. बहुत सारी शराब, बहुत सारा खाना, एकदम से इंट्रा-abdominal pressure बढ़ा, lead to spontaneous esophageal perforation. That will lead to left lower posterior lateral wall tear, and there is gonna be a left chest pain radiating to left shoulder and left arm. Initially we might get confused and mistook with the MI. For that, do the ECG, get it clear, see the subcutaneous emphysema. Meckel's triad gonna be there, vomiting, chest pain and subcutaneous emphysema. VCS, vomiting, chest pain, subcutaneous emphysema on auscultation, mediastinal crunch, that is called as Hammond sign. That is called as Hammond sign. You'll feel like you are walking on the snow. That type of voice is coming, sir. First investigation, chest x-ray. Second investigation of choice is CT scan. Now, water soluble contrast you will use here, because if you will use a lipid soluble contrast, they might get absorbed from the local side or they can cause the irritation. So, gastrographin is a contrast you are using. Now, treatment modality, if you will see, less than 4 to 6 hours if the patient is coming to you, we'll clean it out and we'll do close repair. And if contamination is there, gross contamination is there, for that purpose you have to leave the drain inside, sir. Now iatrogenic esophageal perforation. What is this iatrogenic esophageal perforation? The most common cause is endoscopy. The faulty procedure is the most common cause, and it mostly occurs near the cricopharynx. Why cricopharynx? Cricopharynx is the narrowest structure in the esophagus present at the level C6. What you will do in such condition, if there is a mild tear, you will not allow food to pass through it. You will put a nasogastric tube for 5 to 7 years. Meanwhile, you are eating from the nasogastric tube. That will give the sufficient time to the esophagus to get repaired and get healed. Coming to the foreign body in the esophagus, in the child the most common is gonna be quine, adult is gonna be food, elderly loose teeth or dentures are there. If asymptomatic, give meshy food. If symptomatic, endoscopic removal. So this is a quine. If you see complete margins very clearly, this is gonna be in the esophagus. If margins are not clearly visible, it's gonna be in the trachea. Acute gastritis, very important topic for your exam. Acute gastritis, my dear friends, remember, acute gastritis, NSAID, smoking and H. pylori would be your causative organism. Most common clinical feature is hematemesis. You will have a blood stain, vomiting, and other causes of hematemesis would be peptic ulcer, yes, Mallory Weiss tear, and esophageal varices. All of these three we will be discussing one by one. Now, investigation is upper GI endoscopy, IV fluid will give. If more than 30% blood loss is there, blood transfusion. And also, if we are not able to stop it, we have to ligate the bleeder. Now, Mallory Weiss tear, longitudinal tear in the gastric mucosa. Most common cause is alcohol. Risk factor is alcohol. The cardiac stomach, you will see the longitudinal tear very clearly. This will lead to what's a hemorrhage. Once you will vomit, there will be a hemorrhage. After that, hemoptysis, no, not hemoptysis, hemorrhage you will see with the vomiting. Okay, now coming on to the treatment part, cold saline wash. Then esophageal varices. Sir, portal vein बंद हुआ वहाँ पे, जिसकी वजह से abnormal dilatation in the esophageal vein, tortuous, they can get easily pricked and they can bleed easily. These are the three reasons present behind the acute gastritis and how hematemesis will happen. So these all are linked together and you have to read it under the heading of acute gastritis. Coming on to next topic called as chronic gastritis. Now chronic gastritis divided into two. One is type A, another is type B. Type A is autoimmune gastritis. That means antibody against the parietal cell that will decrease the intrinsic factor that will lead to pernicious anemia. So A is associated with anemia. Which anemia? Pernicious anemia. How that is happening? Antibody against the parietal cell decreasing intrinsic factor, sir. Coming on to the type B gastritis, that is H. pylori is the main reason. How to identify? CLO test, urea breath test. If positive, we give a eradication therapy, or also called as triple therapy. CAB, clarithromycin, azithromycin and PPI we give. Now peptic ulcer, the most common artery which is getting bleeded right here is a gastroduodenal artery. Now remember, the most common site is D1, causes H. pylori, smoking, spices and syndrome like Zollinger-Ellison syndrome. What is this Zollinger-Ellison syndrome? Where HCl production is increased, along with that there is a diarrhea. Now head injury ke andar which ulcer is there? Cushing ulcer. Burn ke andar there's gonna be the curling ulcer you're gonna see. Now how to differentiate between duodenal versus gastric ulcers? Sir, the age in the duodenal. Duodenal is like a dude and dude is young. Gastric is like a poorly elderly old patient. So rich young is dude, poor गरीब is gastric, और जो गरीब है उसके अंदर मुकोसा फट जाता है, और जो अमीर वाली बीमारी है उसके अंदर HCl बढ़ जाता है. In both of them epigastric pain is there, but what special is there? Pain related to the meals. If a pain is happening after 2 to 3 hours of taking the meal, that's gonna be duodenal. If immediately after taking the meal, that is gonna be your gastric ulcer. And pain is relieved by further eating pain. 2 से 3 घंटे बाद दर्द होती है, दोबारा खाना खाओ फिर ठीक हो जाती है. और यहाँ पे जो दर्द ठीक हो रही है गरीब की, वो कैसे हो रही है? आफ्टर वॉमिटिंग. दैट्स गोना टेल यू दैट इज कॉल्ड द गैस्ट्रिक अल्सर. Treatment of choice for both of them is PPI, but in case of your duodenal, we do the high selective vagotomy. There are the complications of the high selective vagotomy, that is your diarrhea. And Rao-XNY gastrojejunostomy is a treatment for the gastric ulcers. Now the complication of gastric ulcer surgery, peptic ulcer surgery, post-vagotomy diarrhea, vitamin B12 deficiency, because vitamin B12 is getting absorbed from the duodenum. Then dumping syndrome, early and late dumping is there. Early dumping is happening because of increased blood to the intestine, and late is because of the reactive hypoglycemia. बहुत देर तक खाना वहीं पड़ा रहा. That will lead to hypoglycemia. Treatment is small frequent meal for dumping syndrome. Then coming to the next topic called as what's a bezoars. Trichobezoar, phytobezoar, lactobezoar. Tricho is hair, phyto is vegetable, lacto is milk product. Bariatric surgery we do for the morbid obesity. Indication is BME more than 35 and comorbidities are present. Most effective would be Rao XN by bypass surgery, where you will shorten the GI tract so that the less food and more satiety will be there. Now, gallstone, cholelithiasis, posterior acoustic shadow, you are going to see cholesterol, pigment and mixed. 3 type of stones are there, important for your exam. Pale yellow color is seen in fat fertile female of 44 eps. Green and brown is pigmenty, grey color is mixed zone. If symptomatic, no treatment. And if symptomatic, so OPD base and emergency, what symptoms the patient is gonna present and how you are treated. Mild pain plus discomfort, ultrasound, laparoscopic cholecystectomy do. Emergency में large stone obstructing the mouth of gallbladder, then there is a sudden severe right hypochondric pain. Pain radiating to right tip of scapula, anorexia nervosa. Clinical examination के अंदर Murphy sign. On putting pressure, there is a pain, and on putting pressure there is a relieving on pain, and on relieving the pressure there is a intense pain. This is called as Murphy sign. Investigation is ultrasound. Now there is a HIDA scan investigation in between this. This is helping in differentiating between acute cholecystitis and acalculous cholecystopathy. Acalculous cholecystopathy is where there is no stone but gallbladder itself is acting like a stone. So to differentiate that, HIDA scan also we can. Then conservative management. If it is an acute attack, the stone is obstructing your gallbladder ka mouth, then you have to do the conservative. In conservative, we do the IV fluid plus IV antibiotic for 5 to 7 days and then discharge with the interval cholecystectomy after 3 to 6 weeks. Other gallbladder pathologies we have to study for exam will be mucosal, cholesterosis and porcelain gallbladder plus Mirizi syndrome. Now mucosal is going to be mucus distension of the gallbladder. Cholesterosis is the strawberry gallbladder where yellow flakes of mucosal surface of gallbladder you will see like this. This is strawberry gallbladder, cholesterosis. Proclain gallbladder is a calcium deposition that increase the risk of the cancer, sir. Proclain gallbladder. Mirizi syndrome, jaundice due to compression of a common bile duct by the large gallstone. If you see the common bile duct is getting obstructed by the large gallstone. This is going to be your Mirizi syndrome. Then fifth is going to be fistula of the gallbladder. The most common site normally your common bile duct is opening the second part of the duodenum, but here the fistula is happening in the first part of the duodenum due to slippage of a gallbladder stone and ending into the distal ileum, sir. If you see the distal ileum ke andar stone and there is a fistula in the first part, you are going to see the regular style. What is the regular trise? Regular trise is multiple air fluid level because perforation is happening in the duodenum plus air in the gallbladder because there is a no stone is present, distal ileum plus stone is present in the distal ileum. The third thing we have to remove. Remove the obstruction. Then cholelithiasis, stone in the common bile duct. Slippage of gallbladder stone can lead to blockage of a common bile duct. The patient can come to the OPD, intermittent jaundice, ultrasound abdomen plus LFT we have to do. Investigation of choices ERCP. ERCP is both investigatory and the treatment modality right here, sir. And we have to put the Dormia masket and we have to remove the stone. Emergency में 4 course triad is gonna pair fever, jaundice, basic resuscitation, ultrasound abdomen, LFT, ERCP plus stenting. In emergency always we do the stenting, sir. Acute pancreatitis and chronic pancreatitis. Another important topic for your exam. Acute में के अंदर there is an inflammation of a pancreas and pancreatic enzyme like lipase are high, and most common reason for the acute is gonna be gallstone. If we compare this with the chronic के अंदर the treatment is gonna be alcohol. And clinical picture is sudden severe abdominal pain radiating to the back, and patient will be sitting in the Muhammad prayer. There is a retrosternal bleed, retroperitoneal bleed. If it is coming on to the umbilicus region, this is called as Cullen sign. If it is going to the flank area, this is called as Gray Turner sign. And patient can go into the shock and the features will be tachycardia, tachypnea, hypotension will be there. In this condition, you will give IV fluid plus calcium. Now, chronic pancreatitis, alcohol is the most common reason than the gallstone. There is a pain in the epigastrium which increase after taking the meals. Plus malabsorption will be there, plus there will be a calcification plus diabetes mellitus, and on ERCP you are going to see chain of lake appearance. ना माल एब्जॉर्प्शन का ट्रीटमेंट पैंक्रियाटिक एंजाइम सपोर्ट दे दो, डायबिटीज मेलाइटिस का इंसुलिन दो, पेन का एनाल्जेसिया दे दो सर। लिवर एब्सेस 3 टाइप्स सर, इंपॉर्टेंट फॉर योर एग्जाम सर। पायोजेनिक, एमीबिक एंड हाइड्रेट। पायोजेनिक स्टेप्टोकोकस मिलरी इकोलाई विल बी रीजन, एमोबिक के अंदर एंटोमीवा हिस्टोलेटिका, हाइड्रेटिक इकाइनोकोकस ग्रैनुलोसिस विल बी देयर सर। दिस पायोजेनिक you will see the treatment is penicillin and metronidazole, and surgical treatment is ultrasound guided percutaneous drainage. Amoebic and amoeba histolytica double rim shape of abscess, you are going to see treatment is metronidazole. Here you will see anchovy sauce, a chocolate pus like appearance plus flask shape ulcer is gonna be there. Then hydrate cyst treatment is albendazole, and treatment is percutaneous aspiration. Now coming to the urinary stones, next topic, urinary stones. Most common kidney stone is calcium oxalate dihydrate, and urinary bladder stone, male child is gonna be your triple phosphate, and your adults is gonna be uric acid. Triple phosphate you are most commonly seen in the kidney itself, not urinary bladder. So remember another thing, in the calcium oxalate, these are of two type, mono and dihydrate. Out of this we have just studied dihydrate is most common, formed in normal urinary feature and lead to what's a hematuria because spiky appearance is there, because of the spiky appearance is there. Now triple phosphate is formed in the alkaline urine, leads to formation of staghorn calculi, formed in the alkaline urine and leads to formation of staghorn calculi. Young males के अंदर common होता है. Cystine is the hardest, चट्टान जैसा. Uric acid is radial, not seen on the X-ray. This is how we have to remember. Calcium oxalate is sounding like a X, and X को हम letter लिखते हैं, that is envelope shape. Then struvite is looking like a staghorn. Staghorn is a dead sign is a rip, that is coffin lid shape. Uric acid is having big U को ऊपर से बंद कर दो, that will become rhomboid shape. Cystine is like a hexagon, six sides is having of hexagon. Now pain related to the stones, important topic. First of all, if there is a kidney stone, there is going to be fixed lumbar pain. If upper 1/3 is involved, lumbar pain will radiate to the testis. If middle 1/3 of a ureter is involved, lumbar pain will be the iliac fossa. And if intramural ureter stone is there, there will be a painful desire to pass the urine. Plus, if bladder stone is there, there will be a suprapubic. If neck of urethra is obstructed, it will go to the tip of penis. Investigation X-ray ki UV. Investigation choice is NCCT. First treatment is relieve the pain. If stone is less than 5 mm, plenty of fluid, more than 5, ESWR more than 1.5, then total percutaneous nephrolithectomy you have to do. Other than that, for bladder stone, lithopaxy with cystoscope is the treatment, sir. Acute appendicitis, most common position is retrocecal, and least common is post-ileal. Most common cause is fecal obstruction infection, and scoring uses mantle score, which is equal to more than 7 will indicate that is you have to do the appendicectomy. What are the signs in the acute appendicitis? Pointing sign, the pain will be demonstrated by the patient. McBurney's pain in the right iliac fossa. Then the Robsing sign is there. There is a pain in the, Robsing sign is there. On pressing the left side, there is going to be pain on the right side. Psoas sign, pain felt on hyperextension on the right hip. If you will extend, there will be a pain on the right hip. These are important signs you are going to see in the acute appendicitis. McBurney, then pointing, Robsing and Psoas. Investigation of choice is CCT. If severe condition is there, operating emergency appendicectomy, grid or McBurney incision we do. Previous year question. Mild, if asymptomatic plus appendicular mass is the Ochsner-Shirin regime, we give IV fluid, IV antibiotic for 5 to 7 days. Then we do the interval appendicectomy, sir. The inflammatory bowel disease, Crohn's and the ulcerative colitis. Site of origin of the Crohn's terminal ileum, ulcerative colitis is rectum. Okay. Pattern of progression, skip lesion, proximal contiguous. Thickness of inflammation, Crohn's के अंदर transmural, and ulcerative के अंदर there's gonna be mucus or submucous. Crohn के अंदर पूरा चीर देता है. Symptoms in the Crohn is gonna be crampy abdominal pain, and ulcerative colitis is gonna be bloody diarrhea. Complication, fistula and abscess formation, and here is gonna be hemorrhagic shock. Here is going to be hemorrhagic shock. Now you will see the string sign of Cantor and skip lesion. This is for Crohn's disease, And lead pipe colon, this is gonna be for the ulcerative colitis. Lead pipe colon, this is gonna be ulcerative colitis. These are the string sign of Cantor. These are the skip lesion, string sign of Cantor, skip lesions. These are the part of Crohn's disease. These are the part of Crohn's disease. Now moving on to the next topic called as what's a bladder trauma. The next topic is called as what's your bladder trauma. Bladder trauma is intraperitoneal rupture and extraperitoneal rupture. Intraperitoneal and extraperitoneal rupture. Okay. The intraperitoneal rupture is mostly happening because of the beer drinking. There is a trauma to the over distended bladder, and investigation of choice here is gonna be your cystogram. And repair the bladder with laparotomy is a simple treatment. Intraperi. Then extraperitoneal rupture कब होता है? रोड ट्रैफिक एक्सीडेंट, जब pelvic bone का फ्रैक्चर होता है. Teardrop bladder, repair bladder with the laparotomy. Both the treatment same, but cause is different. Extraperitoneal, well, pelvic fracture is there. Intraperitoneal, well, there is a over distended bladder injury is gonna there. Then gonna be the urethral trauma, sir. Posterior urethra या membranous urethra, which is the thinnest part, most commonly go in case of a road traffic accident, sir. The DRE पे high lying prostate, blood at the presence of external urethral meatus per pelvic hematoma you are going to see. On DRE you will see the normal prostate. Sorry. High lying prostate you are going to see. You cut this line here. My marker is not working fine. So high lying prostate plus blood at the external urethral meatus plus pelvic hematoma. Treatment is suprapubic cystotomy. Anterior urethral bulbar, manhole injury. Most common urethral rupture in anterior is a manhole injury के अंदर. Blood at external urethral meatus per perianal hematoma. Pelvic hematoma, that will tell you about the membranous, and perianal hematoma will tell you about the bulbar urethra ka injury. Here also high lying prostate you are going to suprapubic cystotomy you will do. Now coming to the next question, coming as a benign prostate hyperplasia, where the testosterone is faultily converted into 1,5-dihydrotestosterone, and the converting enzyme is gonna be 5-alpha reductase. So there is gonna be a site which is most common site, transitional zone median lobe. So your prostate is getting enlarged, that is constricting, and that will lead to symptoms, that is lower urinary tract symptom. Frequency बढ़ जाएगी, number of time you go to the सुसु करने का मन ज़्यादा बार करेगा, flow poor आएगा, there is a retention of urine. Now clinical on DRE you are seeing enlarged prostate. Investigation of choices ultrasound abdomen. Serum PSA level plays very important role. If PSA levels are 4 and less than 10, that's gonna be suspicious of benign prostate hyperplasia. If it is going more than 10, then this is gonna be a prostate cancer. Mild symptoms, drug of choices finasteride, better answer than tamsulosin. Severe symptoms, TURP, that is transurethral resection of the prostate. Plus you will not just put the cystoscope inside and kill it. You will use a fluid also, that irrigation fluid of choice. Here is a glycerin 1.5%. Why we are not using water here? Because if we will use water here, there will be a water intoxication syndrome. Now coming on to the next topic called as hernia. So hernia, if you see, sir, most common in the young male is going to be indirect, in the elderly it is going to be direct. And who is differentiating indirect and indirect? That is what, sir? Your inferior epigastric vessel. That is very important. Inferior epigastric vessel. You can very well see inferior epigastric is dividing your direct versus indirect. Now most common in the young male it's gonna be indirect inguinal. Most common in the elderly male, that is gonna be ठीक है. चलो, let's differentiate indirect versus done. Age के base पे young, elderly, done. Protrude through. If indirect is there, it will protrude to deep inguinal ring, and if direct is there, that is transversalis fascia. And relation to the inferior epigastric vessel, if it is lateral to the inferior epigastric vessel, that is gonna be indirect. If it is medial to the inferior epigastric vessel, that is gonna be direct. This is how you have to differentiate. Now there is a classification called as NICE classification. Class 1 says indirect and 2 says also indirect. Then class 3A is say both. So class 3A say direct, and B says both direct and indirect. Then C is femoral, fourth is recurrent. Done. Now content and classification. If you see content and classification. Chalo. First of all, omentocele. If omentum is coming outside omentocele, if intestines are coming outside, that's it's gonna be enterocele. And if Meckel's diverticulum is coming, everyone knows that is gonna be little hernia. Appendix coming, amandis. Circumference of intestine coming, that is Richter's. W loop is coming, that is Maddle's. Sigmoid colon is coming, that is sliding. Both direct and indirect, pantaloon, femoral inguinal, that is your Cooper's. Name itself will tell you which type is three finger Simon test. Three finger Simon test, you will see, you will press it. On pressing, you will see the protrusion of the hernia. And what is your main aim? Hello, 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 hello. I hope the stream is working fine. Hello, hello. Chalo. Let's start about the most common clinical feature we have done. Aim is to reduce the content and apply the barrier. So open surgery hernioplasty where lich-tensin free mesh repair we are doing. Plus the mesh uses polypropylene. The mesh which we are using is polypropylene. And treatment of choice for the congenital hernia is going to be hernioplasty. And for the congenital hydrocele is also hernioplasty, but after the age of 3 years. Then femoral versus umbilical hernia. Umbilical hernia, Mayo's operation, and femoral hernia, McAvedy, Lockwood, and Lothinston we do. Omphaloceal versus gastroschisis. Gastroschisis mein intestines are coming outside directly, looking very bad. This is called as gastroschisis. Omphaloceal, you will see intestinal contents are inside the sac itself. Coming to the torsion of testis, there is a bell clapper's deformity. Why the bell clapper's deformity is happening? The bell clapper's deformity is happening because of investment of a tunica vaginalis. What is happening? There is a sudden severe pain, swelling, redness. There is a torsion of a testis. Fern test is positive in epidermoorchitis. That means on elevation of testis, if the pain is relieved, that is going to be fern test positive. That will indicate of epidermoorchitis. If on pulling the testis up and pain is not relieved, that is fern test negative, and that is indicative of a torsion of a testis. If a testis is coming to you within 12 to 24 hours, the testis is viable, then we do orchidopexy. And if testes are not viable after 12 to 24 hours, we do orchidectomy. Next coming, varicocele. Due to abnormal dilatation of the pampiniform plexus of a vein around the testis, the most common site is left side. The bag of worm type feeling will be there. Treatment is sclerotherapy, varicocelectomy. Alternate route for this will be cremastic vein, sir. Hydrocele is a normal collection of fluid within process vaginalis. Most common cause is filariasis. So there is a trans-element test which is positive. Investigation is ultrasound, abdomen, eversion of sac with the help of Joubel's operation. If congenital is there, hernioplasty after 3 years will do. Phimosis versus paraphimosis. Phimosis versus paraphimosis. Sir, your phimosis is the extra skin which is not going back. Paraphimosis is skin is back, not going on the tip. So if phimosis is there, treatment is circumcision. If paraphimosis is there, manual reduction is there, and that is how you will treat the condition. Peyronie's disease, hard fibrous plaque एक side पे present है, corpora cavernosa पे, it will tilt the penis. You can kill it with the help of ESWL. Either you can do a Nesbit's operation in which you will build a same plaque on the other side, so that then there is an erection, the penis will be in the midline. Now coming to the next one is fracture penis. Fracture penis. The rupture of tunica or corpora cavernosa. The most common cause is over enthusiastic sexual intercourse, and here you have to repair the tunica. Priapism. The pathological erection more than 4 hours is called as priapism. Treatment is blood aspiration and shunt operation, where you will be deviating the path of the blood, sir. This completes our half of the portion. Then, sir, coming to the next topic called as rectal prolapse. So, rectal prolapse you will most commonly see in the children's. Rectal prolapse you will most commonly see in the children's. तो children के अंदर you will do a digital repositioning till 6 weeks. But adults के अंदर you have to do the Thiersch-Weire Doyle's or Alzheimer's operation. Hemorrhoids, very important topic for your exam. Prolapse of anal cushion, क्योंकि इंट्राअब्डोमिनल प्रेशर बढ़ाते हो, कब्जी हो जाती, जोर लगाते हो, कंजेशन हो जाती है, तो 2 type of hemorrhage, internal and external. Above the dentate line, painless, 3 o'clock, 7 o'clock, 11 o'clock. Below the dentate line are painful. Why they are painful? Because nerves ending are present, sir. Now, grading of the internal hemorrhage are 1, 2, 3, 4. The first hemorrhoid is mass do not protrude out is grade 1. Mass protrude out on straining and goes back spontaneously is grade 2. Mass protrude out on straining and do not goes back is 3. And mass is permanently out, that is grade 4. Most clinical feature is splash of blood. Investigation of choice is proptoscopy. The primary first degree management is sclerotherapy. Second degree, when it is protruding on straining, then treatment is banding. And when they are out, then we have to do hemorrhoidectomy. Now, anorectal abscess, the most common site is perianal space, infection of anal canal, the incision and drainage, diamond shape incision we give. Fistula in ano, abnormal communication between two normal structures. So, infection is a main reason. So, to roll out the interior and the posterior, you can say anterior posterior fistula, there is a rule called as Goodsall's rule. Investigation choices MR, fistulogram, and treatment is fistulotomy. You will produce a fibrosis that will lead to healing and closure of this fistula. Pyloneedle sinus is the jeep driver's disease, where hairy gluteal region is there, and because of prolonged sitting, there will be a serious discharge coming from the pores, and plastic reconstruction is gonna be the treatment. So this is how we have completed our adult surgery also. Now we are left with the only part here is oncosurgery, sir. Oncosurgery. Now oncosurgery, sir. Another 15 minutes and we will be doing complete 3 subjects in 4 hours. Sir, oncosurgery. First number is esophageal cancer. ओए भैया, ओ भाई साहब, हेलो, मैं मर जाऊंगा अंदर गर्मी से, एक चल नहीं रहा ना ये. चलो, esophageal cancer. Esophageal cancer. The most common is squamous cell carcinoma. Opening में most commonly squamous cell carcinoma. Risk factor is gonna be your smoking, alcohol, GERD, Plummer-Vinson syndrome, which is also called as Patterson-Brown-Kelly syndrome. Patterson-Brown-Kelly syndrome. Sir, in this there is gonna be iron deficiency anemia, glossitis, and esophageal webs. In yesterday's T&D session also I have discussed this thing, sir. Long-standing anemia in a middle-aged woman will lead to this, sir. Plummer-Vinson syndrome. Dysphagia initially for the solids, regurgitation, hoarseness of voice because of the involvement of a recurrent laryngeal nerve, anorexia and weight loss. Pencil tip appearance, you are going to see rat tip appearance, you are going to see on the barium swallow. Upper GI endoscopy plus biopsy is the investigation of choice. What about the depth of cancer? Kitna depth hai? That is EUS ultrasound, esophageal ultrasound. Then local staging is done with the help of CECT. Distant metastasis is done with the help of PET scan, and radioisotope which is used here is a 18 FDG. That is what, sir, your 18 FDG. How to do the staging? Number 1 is T. If only one layer is involved, submucosa, that is your T1, muscle is involved, T2, adventitia is involved, T3, adjacent organ is involved, that is T4. T1, T2, T3, T4. Then lymph node is N1, N2, N3. N1 is level 1, level 2, 3 to 6 is 2, and more than 7 is 3. M1, M0 is no metastasis, M1 is metastasis. Surgery, the proximal margin which you are taking in the esophageal surgery is 10 centimeter and distal margin is 5, and the operation name is Ivor Lewis operation, total esophagectomy with the esophageal reconstruction. Stomach cancer now, sir. Next topic is what, sir? Your stomach cancer. Adenocarcinoma is most common in the stomach. Now risk factor is smoking, alcohol, salt, pickle, vitamin कम खाना, and Meniere's disease. Meniere's disease के अंदर क्या होता है? There is an increased mucosal fold thickness that will lead to more HCl. Most HCl will perforate it. Perforation के बाद it will lead to adenocarcinoma. On examination, you will see a leather bottle type of appearance. You can see this filling defect called as linitis plastica. मेलिना विल बी देयर, हिमैटेमेसिस, नीचे भी खून जाएगा, पोटी के रास्ते आएगा, ऊपर आएगा तो मुंह से आएगा, और हिमैटेमेसिस ब्लड स्टेन, वॉमिटिंग और ब्लड स्टेन, स्पूटम विल बी देयर सर, प्लस एपिगैस्ट्रिक मास, वेट लॉस, ट्रोसियस साइन दैट इज माइग्रेटरी थ्रोम्बोफ्लाइबेटिस, genetic is P53 SMARCA 1, local spread proximal can go to spleen, distal can go to pancreas, lymphatic spread you will see virtuous and Irish node. Virtuous nodules are the enlargement of left supraclavicular lymph node, and Irish is the axillary lymph node enlargement. Blood ke through it can go to liver, and direct spread is of 3 types. One is periumbilical, ovarian and rectal. Periumbilical is Sister Mary Joseph nodule, image based question came in exam. Ovarian is Krukenberg tumor, rectal wall is Bloomer shelf sir. Investigation of choice is upper GI endoscopy plus biopsy. Staging is done with the help of CECT. Metastasis pestis, कितना depth है, invasion पता करने के लिए esophageal ultrasound, US. इसको बोलेंगे abdominal ultrasound, AUS. Now coming to the next one is proximal gastric cancer plus in the proximal gastric cancer, if it is there, total gastrectomy plus splenectomy, and the margins taken is 5 centimeter. Distal gastric cancer, partial gastrectomy we do. Colorectal cancer, most common is adenocarcinoma. Most common site is rectosigmoid. Animal fat ज़्यादा खाने से, fiber कम खाने से, smoking and familial adenomatous polyp is responsible for the colorectal cancers. How you gonna know it? Gardner's and Turcot's. Turcot syndrome is familial adenomatous plus brain tumor. Gardner's is familial adenomatous plus the epidermoid cyst. Right colon cancer will bleed and left one will obstruct. Investigation is colonoscopy plus biopsy. You are going to see the apple core defect. Treatment, remember, right hemicolectomy, left hemicolectomy. Hair margins taken in 5 centimeter for colon and 2 centimeter for the rectal cancer. Then anal canal cancer सर, एलन कनाल कैंसर, एनल कनाल स्क्वेमस सेल होता है सर. नीग्रो रिजीम देते हैं कीमोथेरेपी में 5 फ्लोरोयूरेसिल और नॉक्सोप्लेटिन. टारगेट थेरेपी में सेटोक्सीमैब विल गिव. कार्सिनोमा और गॉल ब्लैडर, मोस्ट कॉमन साइट इज फंडस ऑफ गॉल ब्लैडर. टाइप इज एडिनोकार्सिनोमा. रिस्क फैक्टर इज गॉलस्टोन, पॉलिप्स, टाइफॉइड कैरियर, इंपॉर्टेंट टाइफॉइड कैरियर. The carcinoma gallbladder, CCT's investigation. Treatment is radical cholecystectomy, that is removal of gallbladder plus lymph node. Then carcinoma pancreas, most common type is what, sir? Your adenocarcinoma. Adenocarcinoma. Most common site is head of pancreas, very important. Because tail of pancreas पे जो cancer होते हैं, those are neuroendocrine tumors. Neuroendocrine tumor. Then smoking, chronic pancreatitis, diabetes mellitus are the risk factors. Marked weight loss you are going to see in the carcinoma of pancreas. CA head of pancreas, CECT, periambulary camera, ERCP plus biopsy you do. अगर हेड का होगा CECT is investigation sir. And sir, if periambulary carcinoma is there, then ERCP plus biopsy. Marker is CA19-9. Treatment is Whipple's operation. Kidney tumor sir, Wilms tumor, that is nephroblastoma. 5 साल से कम बच्चों में होता है. WT सप्रेसर जीन कम हो जाता है, इसके अंदर इनएक्टिवेट हो जाता है. Investigation of choices, CECT abdomen. Treatment is chemotherapy plus your surgery, that is nephrectomy. Adult hypernephroma, adenocarcinoma, clear cell type of cancer. Most common site is PCT. Smoking and aniline dye space important. Lumbar mass, painless hematuria, and left varicocele will be there. Take a left varicocele will be there. First investigation is urine cytology for malignant cells we check. Surgery के अंदर less than 7 centimeter में partial nephrectomy, more than 7 centimeter radical nephrectomy you are good. Bladder tumor, sir. Sir, transitional cell carcinoma is important right here, is more common than your squamous cell carcinoma. Transitional cell carcinoma is more common answer than the squamous cell carcinoma, sir. Most common side is lateral wall, bladder wall. Smoking dies यहाँ भी important है. किडनी में भी डाइज का काम है, ब्लैडर में भी काम है, सर. ठीक है. Clinical feature is painless hematuria. Urine cytology we do to check the cells. Cystoscopy plus biopsy is the investigation of choice. Investigation of choice for stages is gonna be MRI, non-invasive transurethral resection of bladder tumor, invasive radical cystectomy we have to do. Prostate cancer, sir. Prostate cancer. Prostate cancer. Sir, cancer in the elderly male. Peripheral zone and posterior lobe is involved. Androgens are high. They are the risk factor. Now they spread to the lumbar vertebra through the Batson plexus. All the cancers which spread, they will have a osteoclastic activity. Only the prostate cancer which spread will be having a osteoblastic activity. इकलौता कैंसर जो osteoblastic activity show करता है, and that is none other than your cancer of prostate. Then prostate biopsy, MRI staging, PET scan metastaging, and serum PSA more than 10, which we have discussed previously. Sir, now treatment, if less than 70 years, radical prostatectomy, more than 70 years, active surveillance only we do, sir. And carcinoma beyond the prostate, then we do the androgen ablation by medical and surgical. Medicine के अंदर Gorsalin we give, and surgical management in bilateral orchidectomy we do, sir. If it goes beyond the prostate, sir. Now coming to the penile cancer. सर, स्क्वेमस सेल कार्सिनोमा ग्लांस पेनिस पे होता है. पुअर हाइजीन, HPV, लॉन्ग स्टैंडिंग वार्ड्स की वजह से होता है. फाउल स्मेलिंग, ग्रोथ विल बी देयर. If biopsy will do as a diagnostic part. If glands are involved, only partial penectomy. If penis is involved, total penectomy. If lymph node is enlarged, then antibiotic for 3 weeks we do give. And if they persist to be get involved, then we will remove them. Coming to testicular tumor, germ cell tumor, most common is seminoma, most radiosensitive tumor. Most common cause is undistended testis. Clinical feature is scrotal enlargement, epigastric lump. And if any cancer goes to the lungs, there is gonna be cannon wall appearance. Tumor markers, alpha fetoproteins for investigation of choices, CECT. And chemotherapy के अंदर bleomycin, etoposide, cisplatin. Thyroid cancer we already discussed. Papillary, follicular and medullary. Papillary, follicular and medullary. Papillary में radiation is the most common risk factor. Follicular, large standing goiter. This is Samoma bodies on orphan and a capsular invasion. You will see serum thyroglobulin is a tumor marker, and total thyroidectomy with the lymph node we have to do. Medullary thyroid cancer this is originating from the parafollicular C cells. Tumor marker is serum calcitonin associated with the MEN2, and neck swelling plus enlarged lymph node is gonna be the clinical feature in this. Total thyroidectomy with the removal of lymph node we have to do. So this is all we have to do, and thank you so much. Within 4 hours we were able to complete. And my energy was today low because my AC was not working, plus I was not feeling bad, but still we will not give up till our exam. इसके लिए कोई एक्सक्यूज नहीं होता है. काम पूरा करना है. धीरे हुआ, लेट हुआ, दैट इज अदर थिंग, बट वन टेक होम मैसेज यू कैन टेक फ्रॉम मी, छोड़ना कुछ नहीं है. बीमारी है, नहीं है, कुछ है, जो चीज़ पकड़ी है उसको पूरा करना है. तुमने पकड़ी है, पढ़ाई करके पास होना 26 तारीख को, तुम में उसमें कोई भी एक्सक्यूज़ नहीं आना चाहिए. बीमार हो रहे हो, लेट के पढ़ लो, ठीक हो बैठ के पढ़ लो, बट पढ़ाई नहीं रुकनी चाहिए 26 तक, एंड यू ऑल आर गोइंग टू पास दिस एग्जाम. थैंक यू सो मच फॉर द लव एंड द सपोर्ट, एंड विल सी ईच अदर बैक वेरी सून with lots of blessing to all of you. I'm saying goodbye to all of you. Thank you so much, and keep spreading love for the conceptual medicine. Again, I want to thank Dr. Bhanu sir for organizing such beautiful sessions. His platform is amazing, giving free education to many exam aspirants, and will be keep working throughout this channel to deliver you the content. Thank you so much.